No, never cut people. No, just be aware that we don't sit here at 8 o'clock.
Yes. Okay. Well, I think the
Guan
problem
and Olga, there is there are a problem relating to Olivier Reinberg. Olivier, who has a fantastic experience in this field, has to leave, I think, at 4:30 or 5. So it may be better, maybe, to start instead than with esophageal atresia, with his experience of 300 esophageal, with his relationship, and then we will move to the other talks. So Juan, I know
Juan, if
Mario
you allow,
said to me that I
Juan,
don't want to speak too much this afternoon. You have to manage.
No. I was
this morning I was involved due to the Italian.
I was just saying. No, listen.
No.
Giovanna,
this is prior we start. So
Giovanna,
prior we start, you have to know that there is this need. Okay.
Giovanna, watch this one. Juan.
Yes.
As gentlemen, both we are. Would you mind if Giovanna starts to introduce Olivier?
I'll be happy. Besides, I think it completes the morning, so I think it's better if we
absolutely. We are gentlemen, dear Giovanna. Go ahead. Now, why don't you explain the change and then introduce him, Giovanna? Ladies first.
I'm sorry, I have to apologize, but one of my daughter is giving a concert at 6. And of course, I want to be there.
Of course, not of course. But Olivier, you won't mind that Giovanna introduces you, right? She's the best looking.
I don't mind. I'm ready. Listening to you.
So,
Giovanna, actually, I will be on call from 4 o'clock on. I'm willing to stay here until midnight. That's okay, but I might be called away. So
I think we can hear Olivier and then you, Stefan. So I think
I'm after Darius. It's okay, but
no, it's very good to know the needs of the different speakers. So we know that there is Olivier and Stefan. And so maybe Patosky, then he can go on, but you can, and then the Italian can go later because we are obliged to follow till the end.
Actually, I'll probably be there also till the end, but I might be called away in between, so difficult.
No.
Don't be shy now. Don't be shy.
If I well understand, you will be on call starting from 4.
Correct. Yeah.
So you certainly will finish in advance without any problem, because now it's 2 o'clock. And I think where is Mario? Mario?
Sono qui.
Ok, tu devi iniziare così.
Okay, we start. It's 2 o'clock. We are Italian, but is Italian that is
German Italian.
German style.
Like my friend T. Okay, Giovanna, if you want to start. Massimo.
It's a privilege for me to introduce Professor Olivier Reinberg. He has a huge experience, a fantastic experience in the treatment of esophageal caustic lesion and esophageal displacement. He has a beautiful technique, and I had the opportunity to visit him and to look and to learn his technique that I have applied into children. I have successfully on the surgical point of view. So it's a great pleasure for me. Please, Olivier.
Thank you, Giovanna. Thank you, all of you.
Olivier, I won't say that when I finished my procedure, I immediately phoned to Olivier and say, is okay for you? Or there is a mistake, of technical mistake. And Olivier, that is okay. Now I am very quiet. Thank you very much.
No, Mario, I said 2 things. I said it was perfect, and I said that the quality of the picture, of the video we had was really good. you had a very good material to give optimate pictures of what you've done, and that's very good.
Okay, thank you very much.
Okay, I'll try to share my screen. It's always the same problem with me. Here we are. Sorry. Here we are. Can you see me? Can you see my pictures?
Yeah, but it looks like you have a soft screen or something like that.
Not really, Olivier. So you have to try again.
A little bit oblique, I would say.
Votre partage d'écran est en pause. OK. Is it okay now?
Yeah, yes.
Okay.
Sorry.
Perfect.
Okay. Is it okay like this?
Yeah, it's okay.
Okay, thank you. So thank you to give me the opportunity to talk about our experience in esophageal replacements.
Mario.
It's a long story, especially in Lausanne. My boss, Noël Janton, had done a lot of transplants in between the year 60 and 89. And at that time, he was doing a two-stage replacement, placing the transplants in the retrosternum, and then about a month later, he did an esophagectomy. I developed several techniques, mainly the one-stage orthotopic esophagoplasty, meant to place the transplant in the posterior mediastinum through a closed chest esophagectomy, and then systematically since 2006 by laparoscopy through a transhiatal approach, and this will be my next talk. So I have till now the experience of more than 300 esophageal replacement performed in Lausanne. I'm not taking in account all the other one I've done all around the world. If you want to read all the details, you may find them in the 2 chapters I wrote for Mario Lima in the textbook he edited about pediatric digestive surgery and in other papers. So different to what Michela has shown, most of my patients were acoustic stenosis. I had some esophageal atresia for a long gap, but I never replaced an esophagus in Lausanne for an esophageal atresia born in Lausanne. I had to do esophageal replacement for children who were referred to me, but I never replaced an esophagus born in Lausanne, even long gaps. But I had to operate several very, very difficult cases. Maybe just to mention the most difficult one I have done were epidermolysis bullosa, which is terrific to replace. So I will discuss quite quickly when to replace, where, which transplant, how to perform the 2 anastomosis, the post-op, the problems, and what is the place for minimal invasive surgery in esophageal replacements. So when should we replace the esophagus? I strongly believe that we mustn't do a replacement as first procedure. It has to be a proven failure of a good long dilatation program. It has been written by many others, and my opinion is that we should replace the esophagus after 12 to 18 months of dilatation, not before. For 2 reasons. First, we have a spontaneous improvement, and I will show you. And the second one is we have far less bleeding due to the inflammation when it's too early. This is an example of a 3-year-old boy with an upper GI of acoustic ingestion done at 3 months, 3 months after ingestion. And this is how it looks like about a year later. And you see, we only have 1 remaining stricture that can be dilated. Of course, if we look at this, we would say, oh, we have to replace the esophagus, but that's not true. If we wait, we see that we have other opportunities. Here's another example. This is a little boy, 5 years old, at 3 months after the ingestion, and you see how it looks like 21 months after without any treatment. Now, by the time we're waiting for a replacement, we have to deal with very severe malnutrition. And I have to say, even for those children bearing a gastrostomy, they have acute or chronic pneumonia due to aspiration. We have fistulas between the trachea and the esophagus. So these are difficult cases. And as the surgery will be a difficult one, we have to bring them in the best condition we can with the help of our pediatric nutritionist and gastroenterologist. This is, for instance, a little girl, in spite of gastrostomy, operating gastrostomy and nutrition. This is the way she arrived in Switzerland. This is how she was 6 months after replacement. Where should we place the transplant? We've already been talking about that, and Juan Tovar has already said this. One is the historical route, mean in front of the sternum. This is the one used by Cesarou in 1907. The retrosternal one, which has been used by Mario this morning, which has been used by my boss, is longer than the orthotopic one, because you have to come in front of the heart and back to the neck. And as Juan has said, we have two mandatory kinkings, the one to re-enter the abdomen and the one in the neck. And of course, the orthotopic one is the shorter and the straighter. And as we've said before, in the retrosternum, we have a wide space where a colon can inflate and take any room it needs. But in the retromediastinum, it's like in a box. We have the aorta, we have the lungs, we have the heart, we have the spine. And then even a colon will be in a restricted area, and we have far less redundancy, in my belief, in the mediastinum than in the retrosternum. But if we want to place a transplant in the posterior mediastinum, we have to remove the esophagus, and this will be my next talk. So what should we use? And of course, many substitutes are available: the colon, the gastric tube, the whole stomach, the jejunum, the ileum, and I would like to make some comments on each of them. Of course, I can come in the details. The colon is a very good transplant due to its width and due to the quality of the arteries. The arteries are usually long and wide, and you just have to know that, for instance, we like using the transverse colon vascularized by the left colonic artery, as Mario Lima has done this morning. But about 10% of the population are missing the left colonic artery. And in those cases, we can use the middle colonic artery coming a little more to the right, but we have to adapt to the vascularization. And of course, we never know before what can we use. What's for sure is that it's better to use the colon in the isoperistaltic way than in the retroperistaltic way, because even if the colon has, even if the colon is de-innervated, it keeps some contractions, and it has been proven by Jones and some others that if you put some acid in the colon, you will have a contraction which is an isoperistaltic one. So if you place the colon in the isoperistaltic position, it has a self-prevention against reflux better than the antiperistaltic way. So this, you have seen what Mario has done this morning. We need to have the optimal vascularization we may find. I like checking with little bulldogs, even if Juan has said that he doesn't do it anymore. I've still been doing this because I'm very anxious and I want to make sure that everything goes well. And I check for vascularization. So the colon is a good transplant. mostly the transverse colon, placed in an isoperistaltic way. It has an appropriated diameter. Sometimes it's too wide, it doesn't matter. We can perform an oblique anastomosis, oblique on the upper esophagus and transverse on the colon. It has a good vascularization. It has the appropriate length as needed. And I totally agree with what Juan has said. And I want to emphasize this. We have to take it a little bit longer to avoid any traction on the transplant. And the orthotopic position avoids redundancy better than the retrosternal position. Now the gastric tube was developed by a Romanian whose name was Gavriliu. He did it two ways, but the way we use it for a replacement is the antiperistaltic gastric tube, means that you take the pre-pyloric portion of the stomach up to the neck. At that time, we use either stitches or stapling, and I think that both is quite safe, but if you're a bit afraid, you can staple your tube and then reinforce with some stitches. I want to point out something very important about the gastric tube, because it's a very good transplant, but I've seen a lot of failure we had to deal with. This is due to the place, this is due to the place of the gastrostomy. When we have a gastrostomy to perform a gastric tube, we have to close it. And according to the place of the gastrostomy may interrupt the gastroepiploic artery. Then we have an interruption of the gastroepiploic artery, and the upper part of the gastric tube becomes ischemic. And I've seen many beautiful gastric tube with a firm, strong stenosis within a month, due possibly to the closure of the previous gastrostomy. So according where the gastrostomy has been placed in a previous procedure, you cannot perform a gastric tube. So gastric tube is a very good tube. It can be tailored on demand because the stomach can be expanded as needed. We use staplers, but we reinforce the hinge due to the kinking of the tube. It has a very good vascularization, possibly the best transplant that we can have due to the stomach, but as long as the gastroepiploic artery is intact. We must not use if it has been interrupted by the previous gastrostomy. It can be placed either in the retrosternum or in the mediastinum. When a gastric tube is placed in the retrosternum, it never becomes redundant, as the colon is. Sorry. Now, the total gastric tube pull-up, in my belief, is not a good procedure, especially in babies and infants, because it inflates, it's too large, and then it leads to cardiac problem related to impairment of venous return to the heart. We have a lot of respiratory problems, and it's not true that we have only one anastomosis. In fact, we have 3 anastomoses on a gastric pull-up and frequent leaks. I have to say that this is an example, for instance, of a case Mario Lima had in Bologna with a gastric pull-up in the thorax, and the child had life-threatening events. And among all my cases, I had to undo 12 gastric pull-up done elsewhere for life-threatening events, because it's not well tolerated in babies and infants. Now, the jejunum or the ileum is difficult due to the weak vascularization of the small bowel. It leads to an important loss of unused bowel. This is a drawing by Mario Lima. You see, we have 2 types of vascularization of the small bowel according to the jejunum or the ileum. And Mario has drawn this. If you require this piece of small bowel, you lose this. And this waste of significant length of bowel is a big problem when you want to replace the esophagus. But you may know that the small bowel can be used for something else. And we had to deal with unsolvable upper stenosis, typically after an ischemia of the transplant. And then we can use the small bowel as a pediculated graft, either like a tube or like a patch. And then we widen the stenosis with a well-vascularized tube. This is an example of a stenosis with recurrent stenosis after many, many dilatation. And then we had to use a piece of small bowel with microanastomosis interponate in between the two parts of the esophagus. Or the other way is to patch the stenosis, mean you open the stenosis in its length, and then you put a patch tailored according to the width you need. When we use those pieces of small bowel, we usually do it in 2 steps. The first steps, keeping the tube like externalized to check that the vascularization is good after the microanastomosis. Then in a second step, we patch the stenosis. I'm very often asked which is my favorite transplant, and I never know before surgery which transplant I will use. As I've said, I don't know what is the scarring process in the abdomen. Is there a normal vascularization or some arteries have been damaged? Where the gastrostomy has been done? What's the size of the stomach? For instance, with an unused stomach for years, we have a very small stomach and we can perform a gastric tube. Reversely, when we have a gastrostomy with a well-filled stomach, then we have a beautiful transplant, a beautiful gastric tube that can be done. So my best choice for first replacement is an isoperistaltic transverse colon on the left colonic artery, like Mario has done this morning, or a reverse gastric tube, really on the same level. For a redo, or a re-redo, or a re-re-re-redo, and so on. We can use an isoperistaltic right colon on the right colonic artery, an antiperistaltic right colon, an isoperistaltic distal ileum with the right colon, and this is the case. Mario, you asked the question and I didn't answer. This is the case where we must remove the appendix, otherwise I have no idea, or use the jejunum or the ileum when everything has been spoiled and we have to find something else. So the upper anastomosis is performed in the neck. I never perform the upper anastomosis in the thorax because there might be a leak, and the leak outside the neck is not serious. The leak in the thorax can be dangerous. Through a left cervical incision, careful identification of the nerve, interrupted resorbable sutures, and if possible, we have to keep a part of the upper native esophagus. The 2-3 centimeters of the most upper esophagus are really the most important part to have a good swallowing, to induce a normal swallowing. Up to which level can we go to allow those child to eat? And we have the experience with Philippe Monnier of very, very high anastomosis. We had 25 cases with pharyngeal burns, and I must say, and you have to check, that all those children have intact vocal cords, and you will see why within a few slides. So this is some cases where we had a total closure of the omentum of the esophagus, even a scarring process of the trachea. This is the arytenoids, or here, this is the only opening of the trachea. Of course, there's a tracheostomy below. So what we have been doing is that first, Philippe Monnier, the NT, starts with a laser CO2, and then he cuts the scarring process where I will come with my transplant, and he opens over the arytenoid the airways. Usually, there's only a fibrous process above the arytenoids and nothing else. And then we bring the transplant, whatever it is, the colon or a gastric tube, sometimes a few millimeters from the arytenoid, or if we can, in the piriformis sinus, means 1 centimeter below. And this is the result. This is how it looks like at the beginning. This is the opening after the laser, and this is the colon I brought in that opening. And when you see how these children are at about a month after the procedure, they have 2 holes, one beside the other. And it's just incredible, but they will learn how to swallow with the vocal cords. It takes about 6 months until they're able to swallow something and then avoid aspirations. So you understand why it's so important to check that the vocal cords are intact. But of course, it's more difficult than a simple esophageal replacement. In the Part2, a simple esophageal replacement is about 3 days. It's a week when we have combined lesion. They stay about 2 weeks in our ward for simple. They stay a month and so on. So it's really more difficult. And I will add to this that you have to face the upper the anastomosis is, the higher is the number of pneumonia, of aspiration, of false root, and so on. So about this is for the upper anastomosis. Now about the lower anastomosis. We perform it along the small gastric curvature, and according to the vascularization of the place, we can put it on the anterior or posterior face of the stomach. We use interrupted resorbable suture. I've said why before. So in the literature, we all know that we have a lot of reflux, whatever the technique of anastomosis between the transplant and the stomach will be. So I described, if I remember, it was with Juan Tovar in Madrid in 1993, I described a technique to minimize the reflux of those who were impaired by this. I'm not saying that all cases must have an anti-reflux procedure, but if you have a severe reflux after an esophageal replacement, you may know that this can be done. So you know what is a door wrap? Oh no, first I have to say that having huge reflux, I've done, of course, what I knew. I've done Nissen, I've done Toupet, and it's a total failure because they're too efficient on the soft wall of a colon. It squeezes the colon and nothing comes through. So we had to find something softer than the common wrap we are building. So the idea was to use the door wrap, which is just an anterior wrap, and then we wrap it above the transplant, in front of the transplant, and tailor it to the right cruise of the hiatus. This is how it looks like. We fold the fundus over the transplant, suture it to the right cruise and to the diaphragm, and this has just a kind of valve like a Lorta-Jacob, something like this, to minimize the reflux. This is how it looks like on an upper GI. You see here you have very well the shape of the wrap and the flow in the transplant. When I do my esophagoscopies, I always try to do a version, an intragastric version of my fibroscope to check how it looks like. And you see, this is the shape of a transplant with an anterior wrap. She was my chief president at that time, Sabine Vasseur, compared cases with no wrap and with wrap. And you see that we had about 50% of reflux in our case with no wrap and only 8 with the wrap. And with time, there's no impairment like this, but unfortunately, we have a little bit of recurrence with time, but not as much as with nothing. And it doesn't change anything for the stages. The procedure lasts from 5 to 12 hours. They go in the PICU in postoperative period. They keep intubated for some hours or days. They have a gastrostomy. I feed them immediately on D1 through a gastrojejunal tube. I put through the gastrostomy to the jejunum, and we perform an upper GI 112. These are the tubes we left in place. This is the gastrostomy. This is the feeding tube by the gastrostomy. And as I've said before, I leave a soft tube in the transplant to deflate the transplant to avoid this distension and improve the venous return. If this tube goes away, you must say no one is allowed to replace the tube. That's why we leave a never-ending string coming through the nose in the transplant and out of the gastrostomy. Should a tube come away, we can pull it down, but never place a tube in the transplant blindly. Otherwise, this is what will happen. This is a drawing by 1920 by Chevalier Jackson. So on long term, only the cases performed in Lausanne and only by myself or my team for teaching. We have followed nearly all our cases for several years. And when you compare this to what Michela has presented, all children are orally fed. We have no malnutrition. We have no growth disturbances. Those who became adult have a normal life, but we had to deal with 12% of proximal anastomosis, with fistula in the neck. We've been talking about the reflux, with stasis in transplant, with delayed gastric emptying, with bands, cervical abscess, tracheomalacia, ulcer in the transplant. But I want to point out that in this large series of more than 300 cases, we had no death. So the late complications reported are occasional vomitings, proven GIR, coughing mostly at night, and blocked food. Some patients said that they have a strange taste in the mouth. They eat slowly. They need to drink with meal, and we can understand that they drink to clear their transplant, and they need to remain upright for an hour at least after the meals. Now, the last slide will be, is there a place for minimal invasive surgery in esophageal replacement? And for esophagectomy, undoubtedly. And this will be my following lecture. For which transplant? Yes, for a gastric tube that you can perform with a stapler and pull gently with very few danger in the thorax, but not in my hands for a colonic transplant. Distal anastomosis and anti-reflux procedure, yes, by laparoscopy, but not mandatory as a first procedure. Small bowel interposition, not for minimal invasive surgery, and redo, I don't know, it depends on the cases. So, Oscar Wilde has said, the experience is the name everyone gives to their mistakes, and I did a lot. Another of my mentor was Hervé Blanchard in Saint-Justine Hospital in Montreal, and he always said that in surgery, you can do whatever you want unless you have a good memory. The problem is that surgeons have poor memories and poor statistics. And I thank you for your attention.
Fantastic lecture. I remember with one Toval when we went to Canada several years ago, Gwen.
A number of years ago.
Yes, and we visited Professor Blanchard. I was a young pediatric surgeon. I have to say that I was really fascinated by the personality, but also by the ethics of this, professor. But we had, so.
Olivier, if I may ask you a question, of course, it is fascinating to hear you, and it's an admirable experience that you have. As a German, though, I come from a different upbringing and different teaching, and that is that most German centers over decades only used gastric pull-ups. Not even gastric tubes, but simple gastric tube pull-ups.
Excuse me, Olga. That's very important for everyone to make a big difference in between gastric tube and gastric pull-up, which is totally different. Sorry.
And very carefully, we took care that the interposition is within the mediastinum and not in the free pleural cavity. So based on your experience, what is your suggestion to my or to the next generation? Convert to the colonic interposition, as we saw today, nicely done, or go further with the development of the gastric interposition? What is your gut feeling and your advice?
Well, it's very difficult to answer that question, but I wouldn't, I'm not operating anymore today, but I wouldn't perform a gastric pull-up today because we are treating with infants, babies or infants. And the gastric pull-up is something which has been developed by adults. And in the chest or in the mediastinum of an adult or an adolescent, this is a good technique. But it's not well tolerated to have a stomach which inflates in the thorax of a baby or an infant. So if you have to operate on a child which is maybe 8, 10, 12, and you know how to perform the gastric pull-up in your hands, I think this is a safe procedure, but not for an infant or moreover for a baby. And the other comment I would make is, as I have no experience, I don't know whether it is better to place it in the pleura or in the mediastinum. But I would say that in the pleura, it might be safer than in the mediastinum. Now, the last thing I want to say is that if you have a problem with a gastric pull-up, and I can tell you that we have seen so terrific histories, and Mario can give testimony of this. If you have a failure of a gastric pull-up with a leak, with a totally stuck mediastinum, and a child who failed every day, for instance, and you have to remove this, this is just the hell. If you had to deal with a retrosternal transplant or a gastric tube, you can always do something else.
Thank you, sir. It's an honor to hear you. Thanks.
Thank you, Olivier. I think I would like to follow a little bit the discussion. Do you think that also performing a very good pyloroplasty, the stomach will be anyway dilated? Because in my not so extended experience, I know that if we perform a good pyloroplasty, the stomach will be not so big, also in small infant. The problem is that sometimes it's not the pyloroplasty is not well functioning or well done. But I agree with you that, because I have one case that I treated several years ago with also the help of a very expert surgeon, that if you have a complication in a gastric pull-up, will be a disaster. If everything is doing well, is fantastic. I used to do this technique, and I have to say that I found very, very nice also in the follow-up. But if you have a severe complication, it could be really difficult to treat later because you have a mediastinum very thick, very, I mean, difficult to be treated, difficult to find also another solution. I don't know if Juan has something to add.
One.
Can I? Yeah. Well, it's difficult to argue with Olivier because his experience is enormous. But I have to make a comment on the gastric pull-up. I have made many more colonic interpositions, and I currently will advise colonic interposition. But I have done a certain number of gastric pull-ups, and I think it's an excellent operation. It's elegant. I should say that maybe easier or less, with less suture than the colonic interposition. But in fact, I really practically abandoned that because of two reasons. One, you don't have a gastrostomy. And a gastrostomy may be very good when you have nutritional issues, when you have complications like stenosis or things like that. And secondly, and I think Giovanna has said that, is when you have an important complication, when you have only the stomach and the stomach is in the thorax, that's much more difficult to deal with than when the colon. And that's why I will rather support the colonic interposition, but acknowledging that gastric pull-up may be an excellent operation. And in my cases, I have a number of perfect results with this technique, and I have to say that as well.
I think, Olivier, we may move to the second presentation if there are no other comment or other question.
Yeah, laparoscopic, yeah.
Can you see it?
Yes.
How is it? Yeah.
Okay. Now, this part of my talk will concern only the esophagectomy. So the question raised is, should we remove the burned esophagus? And my answer is yes, even if it's a small yes against a big no. The risk of carcinoma after caustic burn of the esophagus is known for years. But it has always been said that a disconnected esophagus doesn't bear that risk. Mean the risk of carcinoma is related to the esophagus left in place, which is still in use. But this is not true. We have now evidences of carcinoma occurring on a native, excluded, unremoved esophagus after replacement. And I have said before that Juan Tovar has reported cases about that. And this is a strong argument not to leave behind us a potentially dangerous burned esophagus in a caustic burn. But there's another reason to remove the native esophagus. And this is what we have been discussing, is that if we want to place the transplant in the orthotopic position, we have to remove the esophagus. I've been doing that with the technique which was well known, which was called the blind esophagectomy. You were dissecting as far as you can from the neck, as far as you can from the hiatus, then in between with your finger. And I can tell you that this is the most dangerous part of the dissection. And this is the place where are the most severe scarring process, because we have the left bronchus and the aortic arch. So even with a good experience, a lot of cases, the closed chest esophagectomy is never totally achieved. You see that we can reach a total esophagectomy only in about a little more than 2/3 of cases, and with a lot of problem. With more than, 240 esophagectomies, and this is quite a lot, we had a lot of terrific injuries with no death. Tracheal wounds, rupture of the left bronchus, major vascular wounds, aorta, diaphragmatic artery, left bronchiocephalic artery, and so on. So if you add to this anesthetic complication during the blind dissection of the esophagus, this leads to about 20% of complications during the removal of the esophagus. So I've been looking for years to find a way to remove the esophagus under view control and safely. And finally, by 2006, I found a way which I call the transhiatal laparoscopic esophagectomy. And when we did this, we had 40 consecutive patients. And now they're still doing that for all cases of esophageal replacement. And this has been published, so you may find the details of the technique. So this is the view that we have of the esophagus, and we can dissect in close contact to the esophagus, seeing what we are doing, dissecting very gently to avoid any severe damage. This is, for instance, the esophagus. This is the left bronchus. You see here we have a lot of adhesions, and when we see what we are doing due to the laparoscopy, due to our telescope, then we can have a very gentle dissection, and we can avoid any severe wound. So to perform this, I place the patient exactly as for a GIR. I set the patient at the end of the table, and I tilt the table by 30 degrees. Then we have a gastrostomy. We use a telescope in the umbilicus, 2 operating ports on either side, and a 5mm retractor to lift up the liver here. The first idea is to dissect the esophagus and put a loop around the distal esophagus and make a sharp opening by 2 to 3 centimeters at 10 o'clock. You mustn't go at 12 because you have the pericardium. You mustn't go at 9 because you have the subhepatic veins. So the only safe place is at 10 o'clock. And then once you have opened the diaphragm, you take the diaphragm with 2 transparietal stitches and you open the diaphragm. And I like this picture I found in Santa Apollinaria in class. This is exactly what we are doing with the hiatus. We have 2 transparietal suspension thread, and we open the hiatus to come in the mediastinum from below, and even our liver retractor can come behind the heart, and we can dissect like this. So this is how we are. We have our port for the telescope, the 2 instrumental ports, the liver retractor, the threads, the suspension threads with mosquitoes. So this is how it looks like. We have our 2 suspension threads. This is the distal esophagus, and then we are coming in the mediastinum. And we have to come with, and this is very important, the right hand port has to be close to the gastrostomy, because we will enter along the esophagus and work with the instrument in parallel with the esophagus, so we can dissect very easily. We use a ligature, and we can come up to the neck. We mustn't use a harmonic scalpel to perform this because it heats and we may have damage in the mediastinum. For this purpose, we use the ligature. So this is an example, and I will shorten the second video because we're running out of time. This is the right cruise. We open the window as for a reflux. Then we come below the esophagus. I come with a loop and I pull on the esophagus so that we can have the esophagus in line with the port. And when we come in with the dissector, we are in line with the esophagus. We avoid any damage. So we are preparing the hiatus. This is the right cruise. And we're going to open here to widen. Here we are. And we are opening the hiatus. And of course, at the end of the procedure, we put some stitches to reclose the hiatus that we have open. And you will see, here are the threads coming. Here we are. Thus again, this is the left cruise. And this is the view that we have. And you see that with the ligature, we come along the esophagus, so we avoid any damage, and it's easy to dissect in the length of the esophagus. These are some skull that we have to release. This is the posterior vagus nerve. And you see, we can surround the esophagus very gently, and we can go up to the neck this way. This is the left bronchus crossing in front of the esophagus, and we can dissect it very gently. This is the aorta pulsating, of course. And I will shorten because we're running out of time. When I remove my dissector, I put my finger at the highest level I reached. And you can see that we are above the clavicle. The clavicle is underlined by this mosquito. So from the abdomen, we can go to the neck, have a wide dissection up to the neck. This is the removed esophagus. And I asked my two chief residents, Sabine Vasseur and Anthony Debuis, to write about. So they compared 20 cases with closed chest blind esophagectomy with 20 transhiatal laparoscopic esophagectomy. The same indication, the same age, caustic stenosis, and the same surgeon. And you see that the rate of total esophagectomy is far higher than the blind closed chest. Of course, it's longer. I don't argue about that. It takes time to do this. But we never had any vascular oblanchial tear. We had no severe problem. The anesthesists are not requiring any transfusions. And I can tell you that the Part2 are requiring that technique because they believe that the child are far more better about their lung and everything after the laparoscopic procedure than the blind one. The tube can be removed earlier. The length of the Part2 is far shorter, and the total hospital stay, of course, doesn't change. So my belief is this technique reduces the hazard related to blind esophagectomy. It improved the safety of this procedure. We have less surgical complication, less anesthetic complication. Of course, it lengthens the operating time, but it doesn't matter for such a complicated procedure. And of course, it requires to have some experience in minimally invasive surgery. And I thank you for your attention.
Very good.
Bravo.
Thank you.
Very good.
May I ask a technical question, Olivier?
Of course.
Did you ever try bended instruments because of the ergonomics?
Yes, yes. Mario Mendoza had bended instruments, but in fact, it's not an advantage. Really, the most useful point is to be really parallel to the esophagus. Otherwise, you can always surround the esophagus. The problem is to be able to dissect in line with the esophagus.
Thanks.
But at that time, I didn't have the wonderful little, I don't remember the name, the ligature that Steve Rothenberg has developed in 3 millimeters.
Just right, 3 millimeter.
Voilà. Yes, that's.
Yes,
This
can help. It can help.
This can help a lot. Yes, Massimo.
Olivier, really amazing experience. Can you speculate a little bit about I have seen that the laparoscopic technique obliges you to quite a 30% of pneumothorax.
Yes.
Why that?
Oh, I don't know. When you dissect with your finger, you can have injuries in the pleura the same way. But I think that we are pulling a little more transversely, and we have some sharp instruments at the very end. So maybe that's the reason why we have some holes in the pleura. But it doesn't matter at all, because when we have a hole in the pleura, we see it, we put a little tube, and we didn't even stop inflating the laparoscopy. We just have a tube in the pleura.
Okay.
Usually it's the anesthetist who tells me, you have a hole in the pleura. And I say, oh yes, we're going to put a tube in, and we go on.
Yes, that is strange, because in my mind, I think that the manual dissection is more, you can have more damages, and the laparoscopic should be.
Yeah.
More,
you do not insufflate. That's the thing. Yeah.
No.
What do you say?
You do not insufflate with your fingers.
Yeah.
So,
Yes, I think that insufflation can have a role, but there is a Stefan Tigat.
Yeah, just a small question. That did you have any problems with the healing of the diaphragm? I think it opens up the whole new world by opening it up for transhiatal surgery. But did the diaphragm always heal, or did you have sliding hernias afterwards? Anything?
No, I never had. But I think that I would answer two things. The first one, I reclosed at the end, but I have to add that I don't reclose maybe as tight as it was initially, because I don't want to squeeze the transplant. And I closed, I adjust the closure of the diaphragm to the transplant we place in the hiatus. And probably there's a scarring process around the transplant which prevents from hiatal hernia, for instance. But we never had, and I don't think they would have told me, I don't think they have had a hernia since I left, and they're still doing this in Lausanne.
Do you use non-absorbable or absorbable sutures for the diaphragm?
Non-absorbable on the diaphragm.
Okay.
Okay, if there are no more further questions, Juan, in the interest of time, what do you suggest how to proceed? Shall we go give Stefan the microphone?
Yeah.
Or shall Darius start and we'll make 4 o'clock anyway and keep the order?
Anyway, if he has to leave at 4 o'clock, maybe he has to go before.
I think Darius
out of
can go
kindness.
ahead. I stole Darius' title. I don't want to steal his place.
Actually, Stephen, you have to actually ask Adrian whether he is okay with letting you pass him.
I accept every order. So what do you want me? Should I
Juan
start?
is more senior. Juan, you're more senior. Take a decision. Who
Okay,
do you want to hear next?
so Darius should go first then. Okay.
Okay, thank you. So just share the screen. Once again, thank you very much for your invitation. Great honor to be together with you. So I will talk about the technique that we developed at our department that follows the principle of Fokker technique. So this is just a tension repair of long gap esophageal atresia. So we are using internal traction and just want to show you what's our experience. So I will go shortly about the definition because there are a lot of definition. I just show you that I prefer and these are the cases that I will talk only about type A and type B. So I will not talk about long gap for type C or about complicated cases. So these are just type A without any fistula or type B with proximal fistula. And is it a real problem? In Poland, it is just about 10 cases a year. So it's not so much. So it's really difficult to collect a lot of cases. We have a lot of options to do a surgery for long gap esophageal atresia, but I will talk about thoracoscopic and also about preservation of the esophagus. Why thoracoscopic approach for long gap esophageal atresia? First, this is a real minimally invasive surgery. Second, you have a perfect superior mediastinal visualization. You can see every details, especially with today's 4K big monitors, big screens. You can very objectively evaluate the gap between esophageal pouches. So you can count vertebra or even measure it in centimeters. And also it provides you a lot of data for strategy planning. And because this is the initial procedure, this is a minimally invasive procedure, so you can always stop it and switch to other procedures. So this is the first step for all of our patients with long gap. And this is a good example of patient who had 6 thoracoscopic approaches and the scars looks like this on the picture. We have talked today about speed fistula. For us, this is just a procedure that should be avoided because it destroys a significant part of upper pouch. So it should be only reserved for very, very complicated cases as the last resort, life-saving procedure. So just shortly about internal traction technique principles. So this is the upper pouch, lower pouch, the suture between the pouches that keep a static tension. And we started, the first case was, we operated in 2010. So we changed it a little bit. We always start with a preoperative bronchoscopy. No gastrostomy, if possible. Of course, we get some cases that already had a gastrostomy placed, but if it is a fresh case just after birth that is arriving to our department, we don't start with a gastrostomy. Thoracoscopy as early as possible if the patient is stable, if we have all the examination. We usually do it on the 2nd or 3rd day of life, usually in the morning, but sometimes, of course, in the afternoon, never at the midnight. So we modified it a little bit. I will show you in the next pictures. At the beginning, it was almost 4 weeks between procedures. Right now, it's 1 to 5 days, not more. So operative technique details. As you can see, patient is also positioned on the completely prone position at the edge of the table. It's very important because in other way, you cannot move your instruments. The landmark is the scapula. So we place 3 ports around the scapula. I never have to use 4 ports. It's only 3 ports. 5 millimeter for the scope. It's always oblique scope. 5 millimeter ports here. Usually we start with the 3 millimeter and then exchange it with, if we need to place clips. And this is a 3 millimeter ports. Always we use short instruments because there is no place for long one. This is our historical recording, just to show you. At the beginning, it was just a suture, nothing more. This case was operated with 5 stages. Finally had his own esophagus. Then we modified it a little bit. Sure. Okay, hope that it will work right now, not more. Okay, sorry, I don't know what's going on with this picture. You can see, this is the suture between esophageal ends. So I use a sliding knot, as you can see. And the weakest part of this operation was the tension between the esophageal pouches. So it was a limited factor, so we had to stop. And then you had to put clips across it, just to prevent any leakage and disruption of it. Sorry, I have to, okay, oh, no, it doesn't work. I don't know what's going on. Okay, so just to prevent any leakage, we placed the clips across it, usually incorporating a part of the suture. But the tension was a limiting factor. So we modified it, the technique, and the new one is like this. So first we start with a very long suture that is going through the upper and lower pouch. Then we put first sliding knot. And before starting with approaching of esophageal pouches, we put clips across the esophageal pouches. Unfortunately, these clips lock the suture, so you cannot move it through the esophagus. So this is why you need 2 sliding knots on each arm of this line. And you will see at the moment, this is one arm of the line. And you can see the second one with the second sliding knot. In this way, you can create a little bigger tension because it's not only a suture that makes a tension, but the clips that keep the suture and prevent a disruption. So in this case, it was almost 7 vertebrae. And after 7 vertebrae, you can see the final approximation. So it's almost 1 centimeter between pouches. So the baby was operated, the newborn, on the 4th day of life. And this is the same after 5 days. You can see that there is no electrosurgery. It's just only blind dissection. So right now you can see that it was easy, really easy to make anastomosis. But remember, don't cut the suture that keep the tension because pouches contract very quickly. So then you will have a problem to bring them again together. So you can see a very well developed mucosa and just the final anastomosis. This case right now is 3 years old, never had any stenosis, never had any dilatation. If you need another 1 stage, you can use the same knots, the same suture. You just open the sliding knot and approximate it even more. You can see another one example, a very short lower pouch just above the diaphragm. Usually it's about 1 or 2 centimeters above the diaphragm and very high in the inlet of the chest, the upper pouch. And just this is the final after mobilization and placing the traction suture. And this is the same case 4 days later with the final anastomosis. Okay, another one case, you can see sometimes, sorry, it doesn't work. Okay, it still don't work. It works right now, okay. You can see another one case. Sometimes the tension is not so high, so you don't have, this is the upper pouch fistula, so you can see that it was clipped and then dissected, then cut. So sometimes you can use just only one suture, bring both esophageal ends together, and then place clips across just to prevent the disruption. Or just I show you our last case. So we call it everyday internal traction. The baby was operated on the second day of life. Sorry, I don't know why it doesn't work. Okay, you can see the lower pouch. On the X-ray, you can see on the right side X-ray, you can see that the upper pouch was very long. So almost it was possible to make one stage repair, but I was afraid about the tension. I was afraid about the tension. So this is why I placed just the suture, keeping both esophageal ends together. And because this is a really minimal invasive surgery, so on the next day, one day later, we did the procedure. You can see this is one day later. So it was really a perfect anastomosis. You can see with this 4K magnification and resolution, the quality of the picture is so amazing that you can see all the details. Sometimes I even joke that you can see erythrocytes passing through vessels. You can identify all the structure. You can see the mucosa. We always leave a stent in the esophagus. So this is an 8 French tube. Remember that the tube should have the opening at the end in case that you have to replace it. So you can replace it on a guide wire. Okay, so just to shorten it, this is just the final anastomosis you can see. So our personal experience right now, I operated 230 newborns with thoracoscopic approach. So it was more than 320 procedure in different countries, of course, because it's really difficult to collect such a number of cases. So long gap, it's 57 cases, 57 cases. When you analyze the video that we had in 29 cases, median break distance between pouches was 7 vertebra. So of 57 patients, in 5 cases, it was possible to do one stage repair. In one case, we did Fokker, and the other had internal traction. Of these cases with internal traction, unfortunately, we lost 5 patients. In 2, the anastomosis was completed. 3 died before the final procedure. So we completed in 48. 5 cases were completed at the final procedure with other procedure. It was not done by me, only 1 case. And in 43, the final anastomosis was done by internal traction. So if you look at the number of stages, majority of cases had only 2 stages. Some of them had 3. And even in 3 cases, we needed 4 stages. And even was 1 case that had 6 stages, but completed with thoracoscopic anastomosis. And that's our last 9 series at my department that were did without any gastroscopy. So you can see that only 1 case was complicated, so it needed, because there was a leakage from the distal pouch, so it needed gastrostomy placement. However, he was completed with thoracoscopic approaches, but majority of them just needed only 2 stages. So as you can see, the median hospital stay for these 9 last cases operated at my department was 31 days. One thing more. In all these cases, no electrosurgery, no irrigation, no suction were used at the procedure. So since more than 3 years, we are doing all thoracoscopic esophageal repair without any electrosurgery, just only blunt dissection, no blood loss, no blood transfusion, nothing like this. Of course, there are some complications. This is a case, one of the cases that had 4 stages. Unfortunately, the stomach slipped out. This was a case without the gastrostomy, but after laparoscopic stomach reposition, it looks like this, and the baby is doing fine. This is the case that I did with Professor Martin Laher in Leipzig. You can see that the stomach is unfortunately also in the chest, but baby right now is more than 6 months after the procedure, is doing very fine. So we are still waiting whether we have to do any stomach reposition or not. So at the conclusion, with our experience, thoracoscopy for long gap should be considered in each case, but we need a real experience. We need still to master and find the optimal technique. And this is my strong belief that thoracoscopic approach will change the way we manage the long gap esophageal atresia. All the cases that we did at our department were done only by thoracoscopic approach. We didn't have to do any esophageal replacement for the more than 10 years. So is it the way to go? My answer is yes, we should do it. This is the case that had a stomach reposition, but open questions, should we operate 2-3 cases a year in a single center, or is it a time for centralized treatment and very close cooperation for patients with long gap? Thank you very much for your attention. That's a beautiful textbook published recently, Esophageal Preservation and Replacement in Children. We had a lot of knowledge at this book. Thank you very much for your attention.
Bravo, Darius. I'm sure that 120 participants would love to agree and disagree and understand your myths, why you have no little complications, no leakage whatsoever. May I have a suggestion to Mr. Chairman, Juan? In the interest of time, shall we go ahead and have Dr. Tugart talk and then talk about Fokker together, and have Adrian then wrap it up to say repair or replace? Is that okay? Juan, are you there?
Don't work your microphone, Juan.
I totally agree. So it will be good if we go to the next next talk.
Can I share screen?
Stefan, the floor is yours.
Okay. Okay, can you see my screen?
Yes, we see. Yes, we see.
Okay, thank you for the opportunity, and I want to congratulate the whole team there for this excellent live surgery event. I'm very happy to talk after Darius, of course, and as I kind of stole his title. Actually, much of my talk is similar to his, so only what we perform here in Utrecht is the external traction technique, like Fokker originally started doing. So as Darius said, we also believe that the long gap esophageal atresia is only reserved for type A or type B esophageal atresia, which is about 4 cases a year in the Netherlands. So when Dr. Fokker introduced this technique in 1997, he talked about 70 children, of which actually only 9 had a true long gap esophageal atresia. We then started doing that thoracoscopically, and our first series was published in 2015 on this topic. like Holger said earlier today, we think that if you do thoracoscopic surgery in neonates, it's very important to preserve physiology and especially the brain. So we perform brain monitoring with NIRS, and we have post-operative MRIs. And so far, we have not seen any major complications neurologically in our patient group, which is followed up all through life. We start the procedure always with.
Excuse me, Stefan,
Yeah.
don't work your presentation because we see the first slide.
I see the first slide.
Yeah.
Yes.
Only the first.
Presentation mode, yeah.
So what slide do you see now?
We
We are
see
seeing
only
just the first one.
Okay, I'll stop it then. Can you see?
Go for shared screen.
Yeah.
Share your screen.
Do you see what do you see the first slide still?
Right hand, we're seeing your face. Right hand corner at the bottom, it has like a television, shared screen. You need to open that.
Okay, I'll still go to. All right, now maybe. And then I have lots of help here now. Is it okay now?
Yes. Try to go on.
A rigid tracheal bronchoscopy, do you see that?
Yeah.
Yes.
Yes.
Okay, cool. Thank you. So we start off with tracheoesophageal. First we start off with the bronchoscopy, and then we look for the proximal fistula. In our experience, almost half of the cases there is the fistula, and we look for tracheomalacia. We talked about it briefly this morning. If we see tracheomalacia, severe tracheomalacia, we will perform posterior tracheopexy thoracoscopically in the first. When we connect the both esophageal ends. So that's primary posterior tracheopexy in our group. Positioning on the table, we love the way Darius said that he puts the baby more prone, so we put it in left lateral position, but actually then you have more problems with the lung. I saw Steve Rothenberg also sliding the patient forward more. I think that we should consider doing that as well. We leave room for the anesthesiologist to manipulate the tube and also the rip-log tube for the dissection. This is the OR setup. We use normal 3mm instruments like you all have. And so we start with a video. So this is the OR. Patient is on the left side here. So if you, can I pause that? Okay. So we don't use any electrosurgery like Darius does either. So it's only blunt dissection. We use this little remnant from the distal pouch to lift it up. We have this little plastic tube to lift it out of his esophageal bed. We go all the way down to hiatus, and we try to prevent opening it. Proximal pouch is just like in type C surgery. We can find it and we can lift it out of his bed. Now, this is the external traction sutures are introduced by this endoclose device. Sutures are placed through the whole wall, so including the mucosa and the lumen, and then brought out again as low as we can through the ribs. 4 sutures are placed in every pouch, so it's all done thoracoscopically. We don't try to touch the esophagus as much, but we try to prevent touching the esophagus as much as we can. And we could still dissect the proximal pouch here. You can see you can use to manipulate. This is the endoclose device which you use to bring in the needle. We go as high up as we can to get most length for traction sutures. So it's brought into the thorax, and again in the distal pouch, the sutures are placed through the lumen. We try to have this like what we call like a no-touch technique. So 4 sutures on each side brought out, and they are like in an X shape. Traction is applied. So you also place clips on the sutures near the tip of the pouches. In this video, you can see we put 1 clip on one side and 2 clips on the other side, so it's easier to see on the postoperative X-rays the progression of the traction, actually, if the pouches still come together. On the outside, the sutures are placed through this little plastic tube, and baby crowds or mosquitoes are placed on it. And with the thoracoscopic images, we can see what kind of traction we can apply. You can see like already the bridging of the defect. We line the 3 working ports a bit more straight, not like in a triangular fashion. This is the extra port we use to keep the lung out of the way, so that we can work also towards the lower pouch, which is on this side. And these are the mosquitoes here. This way, actually, the patient has to go back to the, after we perform a gastropexy, the patient is positioned also in an intensive care unit. We don't go in every day to put more traction on it, just leave the traction on it. We just see that the clamps don't slide off. There's one slide of the laparoscopic gastropexia. We do that since we saw, like Darius showed also, sometimes that the stomach has the ability to slide up into the thorax. So postoperative images is one of the first cases. So start off with about 4 or 5 centimeters, and then after 5 days, the clips start to come together. If we don't see enough progression, then we will go back and do adhesiolysis and take the lung out of the way, and put pressure on both ends again. This is actually 7 days, the same patient, 7 days later. You see that both ends have gained a lot of extra length. Like Darius did also, we leave the traction sutures in to start placing the first sutures. Kind of helps you and it prevents from both pouches to slip away again. So the tumbling knot or the sliding knot is crucial in this type of surgery. Once you have placed some, then you can cut off the tips of both ends, and you can see the nice alignment of both ends. And we try to gently approach them to get them closer with every suture which we apply pressure on. So now halfway, bridging the gap, we will introduce the nasogastric tube. This helps truly to keep them straightly aligned so that it's easier to get them together. So you can nicely see that the tissue is vulnerable, but gently, very gently, it's possible to get both ends together. First the back wall and then the posterior wall. And the anterior wall is also closed. Now, we do see leakage in these patients, so we always leave chest tubes. That way we can always deal with the leakage, and if there's no leakage, then we can take them out again. But putting them back in later is more difficult, in our opinion. So a summary of the technique. So I think it's crucial to start with bronchoscopy, both for complicated tracheomalacia, which could be difficult to deal with in a later stage, and see if there's a proximal fistula. In our case, it was 50%. We don't perform any gastropexy anymore, but we don't do any gastrostomy anymore, but only gastropexy, especially if we open the hiatus. Full thoracoscopic mobilization without any electrosurgery. I think the lumen, the traction sutures should include the mucosa, and it's not like this is one of the Fokker images where you see that only the muscle layers hitched. We think the lumen should also be attached, otherwise it will be very difficult to find the lumen and open the mucosa. When the patient is placed in the intensive care unit, only light sedation is necessary. We don't have to paralyze the babies, just keep them comfortable for a week. So we do perform adhesiolysis if we don't see any progression of the traction sutures. We leave chest tubes, and we perform a contrast study after 1 week to see if we see any leakage. If we don't see any leakage, then the child can start drinking. In case of stenosis, we will perform balloon dilatations and the fundoplication if there's recurrence of strictures formation. Recently, and I'll only go to the highlights. Last year, we published the childhood outcome of this group of patients. So initially, we had 13 patients treated this way. 2 actually had failure due to suture disruption and perforation of the pouch, and then 1 had a gastric interposition and another jejunal interposition. But median age discharge home was in our series 45 days. And earliest discharge home with the functioning esophagus was 31 days. First oral feed on median day 16. So already from day 5 after anastomosis, the child could start learning to drink by itself. All the children needed dietations in the first year mainly, and 10 out of 11 had a fundoplication. We looked at the growth in these children. Now they are a bit below average when they get born, but they do tend to go to like comparable to normal healthy control kids in the Netherlands in the years to follow up. We did look at the quality of life. The little blue lines here are the -1 standard deviation in the normal population on all these scales. And our children have comparable quality of life as their siblings or normal kids. So in conclusion, we would say that the external traction technique provides good long-term results. So we do operate them from in the first week of life. So the correction is possible within the first weeks of life. Oral feeding can start within the 1 or 2 weeks after the surgery. And most patients are growing within the normal range. Quality of life is comparable to healthy controls. And almost all of our patients, except for 1, actually reach an age-appropriate oral diet and has a normal life, actually. Maybe for the discussion now, we think that long gap esophageal atresia is atresia. I would say that the native esophagus is probably the best way to go. Primary anastomosis would be the procedure of choice, either delayed or with traction technique. We also think that cervical esophagostomies should be avoided because then any lengthening technique is no longer an option. And we think traction technique is well tolerated and can achieve anastomosis up to 6-fold earlier than a delayed primary anastomosis. I want to thank you very much. I would still say that we also have international referrals to our center, and I think Darius is right that if you want to do this, it should be in a center where minimal invasive surgery is performed more often. And here in the Netherlands, we have decided to treat all Dutch cases together with Amsterdam and Rotterdam and Utrecht. So there's a team of 3 centers, and then as there's a Dutch child with long gap esophageal atresia, we will treat it together. Thank you very much.
Well, Stefan, great talk. I talked to Mario earlier. I think, after hearing both of you, the worst that could happen to this meeting is that about 100 younger participants leave and say, well, that's obviously gold standard. I still consider both of you the best in the world. And the question is, why do you avoid all these complications that I have seen in my life? And if you allow me, I would like to briefly share my screen, zoom through our old study, pinpoint some complications, and then you have the floor to decide whether thoracoscopy changes everything or nothing. Is that okay for all of you?
Okay. Okay.
I'll be brief as possible. Okay, for a couple of years, John Fokker came to Leipzig and to Gdansk and directed his patients to our 2 centers. We collected only 15 in the good old open way, the old stuff that you see. And we grouped them into 3 different groups to understand what makes sense and where's the limitation of all of this. Group A, like we saw today, both pouches. Group B, spit fistula, left or right. So we had to think about it, whether we can gain any length from that with Kimura, and or group C, we closed that spit fistula to Fokker it. This is a simple case that you all know. I think the most interesting thing in this video is the severe tracheomalacia. But anyway, now they go as you showed. They advance nicely. You check for the x-rays. You have these huge bulky things that you do an anastomosis with. Fine. I think everybody enjoys these cases. Or group B patient with a spit fistula on the left side from Bangladesh, 5 months old, median gap, not an ultra long tracheostomy in place. You advance them both. You check for the lumen with the endoscopy. And here you go, you repair it. Now, these are the stories we heard so far. But why did we in Leipzig and Gdansk collect these patients? Number A, from group A, a patient with an upper fistula. Okay, you say you close it. That's what we did. And then you put it back into and advance it with a Fokker. Fine. Advanced anastomosis. But watch this. 4 weeks after an uncomplicated anastomosis you just saw, with a gentle attempt not even to dilate it, but to calibrate it, it simply busted. We called this an atrophic fibrosis, and maybe Darius pinpointed to already don't use any cautery. But the point is, the tissue is not as good as you think, maybe. This is stretched. Where is the blood supply? Okay, so I resected it immediately, same day, and it healed. Next example, spit fistula on the left, hardly any distal pouch. Now, Darius, do you think you can grow this or even stretch this to a different length? We scoped it a couple of days later, and the scope is below the diaphragm. That's the message, okay? That patient never got enough length. Even with all Fokkeri, the lumen stayed behind, just above the diaphragm, and we advanced the spit fistula as good as we could, but we saw non-responder. How do you deal with that, Darius and Stefan? And then finally, of course, those patients, this is a typical really long gap, an ultra long gap, hardly any bud on the stomach, spit fistula. We closed that spit fistula and we learned our lesson never to close it and use it for Fokker because they bust, they perforate, they cause all the complications that you don't want to have. And here it is, even after the anastomosis again. 10th day after the primary anastomosis, spontaneous breakdown of the anastomosis. Didn't even touch it. It just fell apart. Was a small leak, we drained and left it. So I'll already come to the conclusions. Question, is that me, the second guy? And are you the cool guys? Or why do we see tension, ischemia, atrophic anastomosis, leakage? Thanks, guys, for giving me the chance to add that just to get the picture complete and put some water into the wine.
May I start? I think Darius and I, we would like to advocate that, especially on the left side, a spit fistula is actually the worst option you have. I asked many people who perform that on the left side and say, we always did it on the left side. If you would place on the right side, even that would maybe keep more length. So I think it's also, every procedure you do, and especially if previous surgery, it does hamper vascularity as well. So these, in our experience, these children, you can do this surgery, this type of surgery from day one they're born. So maybe it's also the previous surgery, which can be a problem, and or the open dissection. I don't know. Darius, you have another option?
Thank you, Holger, for your presentation. As you showed us, most of your patients were older children, not newborn. This is the first thing. When we think about waiting, probably there's a spontaneous growth of esophageal pouches, but later also patient is growing up. And of course, there are also 5, 6 vertebrae, but vertebrae are growing up also. So the distance is becoming bigger and bigger. In my series, just recently, I operated 3 cases in Kazakhstan and 2 cases in Munich. And all these cases were 6 or 5 months old. And it was really very difficult to bring both esophageal ends together. I managed to do it, but it was really difficult. So first, we start at the newborn period. And also, the very important thing is experience. Behind my 55 long gap esophageal atresia cases are 150 cases of type C. So altogether, it's more than 200 babies, you know. I'm always present at the procedure. There are also other guys who do it, not only me, but I am always, in majority of these cases, I am always present. So probably experience plays a very important thing. It's a very important factor, yeah? And to my opinion, we should start it very, very early. It's much easier to do it. Tissue, you know, I had only 1 case that I had to do other procedure. I mean about Colles procedure. Okay, there were more 5 cases with Colles procedure, but just only 1 case that I had a complication with the leakage that I had to put a split fistula. But it was a life-threatening event I couldn't manage. 1 case in 55 cases.
Without any doubt, you are an expert. And the point I'm trying to make is that technique already everybody's darling, or is that only in the hand of 5 to 10 people in the world? See, when you say, let's start early, I believe you. And one of the reasons for believing both of you, I mean, because you're trustworthy colleagues and fine guys, but also when you say, let's do it early, this comes back to Prampuri's theory of waiting for spontaneous growth within the first 3 months of life. Okay, so maybe these non-responders, yes, are the older children, but imagine that people who don't have 10 or 15 cases of normal esophageal atresia start to do traction sutures on these delicate esophageal remnants of 2-day-old. Honestly, I've published a long time ago a nice case from a different hospital in Germany that was a total mediastinal mass. There were fistulas after Fokker on the 2nd day of life, mediastinitis, mucoceles everywhere. So Fokker, and you too, always make sure that you do not go through the lumen of these fine esophageal remnants. Otherwise, you have mediastinitis. So it's getting even worse, more hard to do it in a newborn. What do you think?
You know,
it's getting more difficult technically, huh?
I always try to incorporate both muscularis layer and mucosa. So I take a deep bite of tissue, and just to prevent any leakage, I put clips across. This is my strong belief that it prevents leakage. And also very important thing that comes from experience is attention. Attention. So at the beginning, we had leakage. And the disruption. Even my first Fokker was disrupted completely, you know, my first Fokker. So I cannot say exactly what's the factor, but probably there are a lot of things that are unconscious and a little bit maybe, that we think that it's normal, but somebody is doing it in other way. Maybe coagulation. We are not using any coagulation, just blunt dissection. There is no hemorrhage. So probably blood supply is a little bit better. I never cut azygos vein, never. I don't know how to do it. You know about my opinion.
Oliver, you wanted to say something. You raised your hand.
Thank you. I just want to ask a question. In fact, it's a fascinating discussion. We have said, Juan Tovar and myself, that in very long gap esophageal atresia, you wait and then you can perform the anastomosis. You have shown, both of you, Stefan and Darius, very convincing technique. But I understood what Darius has said, you have to do it early. So is it in total contradiction, waiting for a spontaneous elongation, or operating early because it's a very young baby and performing your elongation technique? Is there a rule to choose one of these choice, because they seem to be totally antinomic?
May I comment on that? Actually, it's not only the surgeons, it's actually the whole hospital, which has to be, all specialists have to be involved, and these kids need special care. So, for instance, they have a microgastria and they have a gastrostomy, and it's very difficult to get them on full feeds on that. If we have patient transferred, usually they're not in the best clinical condition to have this type of surgery. And Holger, in the first video you showed, what you saw is like total aspiration of contrast in the trachea. The second patient had a tracheostomy already. So that can be already complications of the prolonged waiting and the problems you had. So you have children have multiple respiratory infections, probably, or aspiration continuously, usually not in the best nutritional status even. And then you're going to do secondary, tertiary surgery with suboptimal results. So I think care for these children starts like way before birth and trying to determine which children are. If you want to treat long gap esophageal atresia, I think it should be in a center where at least, you said, like 7 or 10 or maybe 20 cases a year are operated, because this is really difficult surgery in a way. Maybe we make it look easy, but you need experience for that as well. But not only a surgeon, but an anesthesiologist, as I mentioned, the brain, for instance. So it's the whole package. And I think when Ernica, we had a conference on this with Ernica, then we said that especially the traction technique, now maybe we should think about centralization of these children. We have had surgeons with their, especially last week from Ireland, here with their patient. They are here at the operation, but and maybe you should transfer the child or like that. Consider that.
Agree. Stefan, a technical question to you and to the audience. If you had the choice between internal and external traction sutures, what would you go for? In other words, when you do external, do you think you have a feeling how much tension you actually put on the esophagus inside the thorax, because while the suture is passing through the thoracic wall and the resistance?
Yeah, actually, I think so. We, of course, I learned the external traction like Volker did, and of course, we saw the results of Darius, and I'm totally pro what he does actually. But as an institution, we decided because actually this surgery is not only done by me, but by the whole team here. So we decided not to change our technique, because we're used to it. Intensive care is used to it. But we love the way Darius positions his patient. We already discussed that just now. We like the way the internal traction. So maybe the future is internal traction. I don't know, but traction is the future, and thoracoscopy, in my opinion.
Darius, you raised your hand.
I just want only a few words. Of course, Stefan is very right that surgery is a teamwork. So it's not only a surgeon, but the whole team, anesthesiologists, nurses. And for instance, at my department, we are not using Replog tube. We just use only suction on demand. You know, if you use a Replog tube, you dry the mucosa of the upper pouch. We hate it. Since 20 years, we are not using any Replog tube. Maybe this is also a very important factor. Suction on demand. It's not necessary to place a tube that is always blocked, always dry the mouth, always dry the throat and upper pouch. Think about it. There are small tricks, maybe that change the surgery. I don't know which one is very important, but this one is for us very important.
I think Vincenza, I saw her hand. Vincenza? Are you there?
Somebody asked to talk. Oh, Vincenzo.
She raised her hand, I think.
Yeah. Anyway, she disappeared.
Giovanna, yes, I would like to. No, I am always fascinated by your presentation, Darius and Stefan. But I know the experience of Olga, and I have to say that I had a case that I treated with an expert who had a bad outcome. And this was, and the reason, in my opinion, was the age of the patient. So because the technique was fantastic, was made by an expert as you, but the results was terrible due to the age, in my opinion. Because if we treat a patient in the at a early age or during, we know that the period for spontaneous lengthening of the esophagus is at least 8 weeks. 8 weeks. So if we treat a patient at 5 months, 6 months, 8 months, my patient was a delayed treated too, I think we lost the opportunity to have the possibility to obtain a good elongation. So my suggestion is why you that are called to perform a procedure worldwide, because you are considered the main expert, why you don't analyze very well the different results in newborn and in older children. That could be I mean, could be interesting on the scientific point of view, but also to clarify the right indication of the technique. And I would like to thank Olga because he tried to underline how it is not allowed to someone who is a young surgeon to perform this procedure, because it's a very beautiful procedure, very nice, but he cannot understand how difficult it could be.
Professor Lima, Juan, sorry.
Just a comment. You cannot discuss successes, and I think both Stefan's and Darius' series and the films were very convincing, and I think the results were excellent. So you can argue against that. But I was trying to figure out how many anesthesias you needed to put these patients out of the problem. So you had at least 2 thoracoscopies, or when at the time of Fokker, at least 2 thoracotomies. Then the average dilatations were 6. Was that right? Is that right? And then a fundoplication in almost all the cases.
No,
so,
just only single cases.
Well, that's I think I'm talking about the slide, Stefan's slide that put that. 10
yes,
out
in my group it was.
10 out of 12. That almost all had a fundoplication. This was many other cases of esophageal atresia have that long gaps. But in fact, if you take all together, I would like to know the average number of anesthesias all these patients have from the beginning to the end of the procedure.
In majority of my cases, there were 2 or 3 dilatation. I cannot recall only one case that had more than 5 or 6 dilatations. and just only a few of them needed a fundoplication. Most of them are on conservative treatment. Just recently, I had a case who was 9 years after a long gap esophageal atresia repair. And just right now, we think whether it is necessary to do a fundoplication because there are a Barrett esophagus on endoscopy, but the baby is not vomiting, nothing more, no stenosis, nothing like this. So I don't think that they need much more anesthesia. And majority of my cases had only 2 stages. 60% of them had only 2 stages to get esophageal anastomosis. Yeah.
Yeah, I asked that because at the beginning of when Jack Fokker introduced the technique, I discussed with him in one of the first meetings where he presented his cases. And at that time was thoracotomy, was not thoracoscopy. But then he had almost half the patients had to a resection of the stenosis. No, I'm not talking about your cases. I'm talking about the Fokker's, Jack Fokker's techniques. And he had 100% fundoplications and an average of dilatations of 12. So that's his own data. So you improve certainly the results, and your techniques are certainly better. But in some way, I think for the young pediatric surgeon that is mesmerized by the beauty of what you have presented, I think they should take into account that not all people can have the same results, and that maybe they will be confronted with complications as the ones I have mentioned.
But you know, in Poland,
can I just add to what Juan has just said? And all Fokker's cases had the stomach in the chest and required fundoplications.
Yes.
So the concept of having had growth by pulling doesn't apply because he pulled the stomach through the hiatus into the chest.
Yeah.
Now I've seen your presentations and Stefan's, and they are mesmerizing. I don't deny that. Congratulations. But you both have stressed that you need how many cases? 150 before you start? How many average everyday surgeons around are going to have that opportunity? So if you're going to push these techniques, it seems to me that the first point is to have a national center, or at least a center, 1 or 2 centers in a big country where all of these cases go and no one else is allowed to operate on them.
Okay,
now,
but
how realistic is that going to be?
It's really easy to do it. Look, in Poland, 40 million people, inhabitants, we had about 120 cases a year. So if you create 3 or 4 cases that will do 30 cases a year, it's okay. It's not a big problem with the transport right now, you know? So I don't think that it's not unrealistic. Look what happens in the UK when they decided to centralize biliary atresia. The results improved significantly. So it's easy to do, especially that there are special cases. 120 cases to collect in 4 centers, it's easy. It's not necessary that each young surgeon should do esophageal atresia. He should know how to do it, but it doesn't mean that he has to do it.
I agree with you entirely. I live in UK and I have spent all my career in UK. Do you know how many subjects there are where there has been success at setting up a single center or 2 centers, like for biliary atresia in the UK? Only one other area for transsexual patients and such like. Everything else has failed because surgeons are not prepared to give up work to other surgeons. So it's not as easy as all that, I'm afraid.
But we
should. I agree with you. I am in agreement, but it's not easy to set up.
But maybe parents' organizations will drive that.
That's true. You are right. We have a lot of patients not referred by doctors, but only by parents who refer to our center. They applied just to admit their newborn to our department. That's the majority of patients right now.
Okay, I don't Professor Lima, Mario, would you like to add to the discussion before we go for the final question to replace or to repair?
I am here, and it's very interesting discussion, but I remember to the chairman that I have some presentation, and if it's possible, we continue with the presentation. Olga,
Okay.
you agree? Also, the senior chairman.
Yeah. Go ahead.
You agree?
Now then it's absolute time to give Adrian Bianchi the stage and the microphone, because he will go for the question, replace or repair. Adrian, thanks for being so patient with us, and go ahead.
Let me see if I can get there. Share screen. Okay, can you see my screen at all or not?
Not yet.
Or
Can you see now?
no,
No, so what am I doing wrong?
I had to double click on the little box.
Yes,
And I just,
I'm trying.
I had help.
I'm trying very hard. Hang on.
yes, you are.
Stefan, tell
Are you
him.
seeing now?
You tell him.
Are you seeing
Yeah,
now?
yeah, everything is fine.
Everything's fine, except
Michelino.
I'm not seeing now. Hold on.
Go for full screen and you're fine.
Yes, I'm trying. Where is full screen?
Down, down.
I
The
never
little glass.
expected. I never expected to
there.
have this problem.
Yes.
Oh,
Down.
Down, down, down. Right. Yeah, right.
yes, I can't go
Yes.
more right
Next,
because
next,
Next.
over there.
Down.
This is robotic.
Yes,
This is
tell me,
robotic,
because
yes.
I'm seeing your pictures and I can't get rid of them. I don't know what's happened here.
A little glass.
No, take your cursor and you're right
Yeah.
there. That's it.
Yeah.
Are we all right now? But I
Yes.
don't
Great.
see you.
We see very well.
Ah, okay. You can see well. Okay. Well, Mario asked me to speak about the reasons why I do what I do. I'm afraid this is going to be rather a letdown after all that you've just been hearing with these new techniques. So in a way, what I'm going to speak about is my personal journey throughout my career, starting with what I was taught and then how the principles and the reasons why I slowly changed my ideas to what I now believe in. As you said before, some people call it experience, I don't know. But my concepts changed as I went along as to what was relevant and important for me and for the patient. So esophageal atresia, as we have seen, presents us with many different pathologies. There is the esophageal problem, the top four coughs, the trachea, and particularly tracheomalacia, and then all the other associated anomalies, vertebral, anal, cardiac, chromosomal, renal, limb anomalies that we also have to keep in mind. And then there is the treatment. Sorry. Can you mute your microphones, please? And then there is the treatment. What should we do? How should we do it? We all agree we should divide away the tufts. Do we tie them? Do we suture them? Do we leave them open? And is it one? And remember that there may be more than one tuft. At the same time, do we go for reinforcing the trachea? Do we go for treating the tracheomalacia? If so, when? So this child, for example, was a severe case where there were no cartilages in the whole of the trachea. And the child could not breathe, and the mother refused outright to have a tracheostomy. So we repaired this with 11 costal cartilage ring grafts, which we placed intermittently down the trachea. And the child did extremely well and never had a tracheostomy. The esophagus, which is what we've been talking about today, is obstructed. The upper pouch is almost always markedly dilated. There is the distance that you have been hearing about. There is what type of anastomosis we should do and how much tension is permissible. And then there is the complications of the surgery that we do, that we have to consider and try to avoid. If we have a TOF again after surgery, is it recurrent or is it what we have missed? Stenosis has always been a major concern. Anastomotic dysfunction, if we take a big upper esophagus and we join it to a smaller one, we create a funnel and there is delay in passage with collection of food and saliva in the upper pouch, which leads to aspiration in the neonate who is lying down all the time, and lung problems. And then there is the question of pulling the stomach through the hiatus hernia, and the ever constant bugbear of reflux. What we didn't mention, and what I believe to be very, very important, is the timing of the repair in relation to brain learning, the physiology of the child. When does the child learn to swallow? When does the child learn to taste? When does the child does the child start to accept different types of foods in order to avoid food phobia and such like? And of course, along the way, there is the growth of the child. And we mentioned earlier in the day the issue about aesthetics. What do we leave behind? Which is maybe not so important to us. We have concentrated on talking about esophagus, but we have never spoken about the type of scars that influence the child who becomes an adolescent to whom body image is so very important. And all this the surgeon has to contend with before he even starts to think of, does he do an open thoracotomy or thoracoscopy or robotic? And the experience factor that is required there. So any surgeon faced with esophageal atresia has to be considering all of these issues in determining his approach. To my mind, esophageal atresia presents an interesting but a very significant challenge to any surgeon who is going to undertake it. Okay. We mentioned just now that perhaps we should ask the parents to vote as to what they wish, and parents to a certain extent do. And the TOF Association produced the TOF book here for information for parents and for surgeons. And what they actually say in the book on page 95 there is that at birth, the baby likes sweet foods. And by 3 to 5 months of age, he begins to develop new tastes based on the taste of the food and the smell of the food that he has been given. And by 6 to 12 months, he starts to try to feed himself with more solid foods, puts them in his mouth. And it says here, this is derived from parents and what they were told, what they told the authors of these chapters, that a lack of ability to eat normal type foods at the right time may lead to very poor acceptance of different textures and different foods, food phobia. So to my mind, and this is where my thoughts over the years from a young surgeon as I got older started to change, is that early oral food is absolutely essential to physiological development of the brain. And in fact, if these things do not occur at the right times, then those cells responsible for them in the brain die off, and the child never acquires the same level of food acceptance and food joy ever again. It is important to avoid food phobia, whatever our plan of management. So my concept, if you like, and my guiding principle is that our surgery, our timing of surgery should be guided by neonatal physiology, not by what we can do and what we can't do. We treat the child according to his needs, not to the needs of his esophagus only. Neonatal physiology should guide our reconstruction. To my mind, and again, another guiding principle is there is no place for delay in oral feeding. Do it as you wish, whichever way you wish, but that baby needs to feed normal volumes, normal amounts of normal foods at normal rates. Now, we have always been taught, and I was brought up with this edict, which could never be broken, that the best tissue for esophageal reconstruction is the native esophagus. And we are still working on this principle, as we have seen in these lectures we've heard today, which is good. In my time, during my years, I'm now retired for some 12 years, in my years of reviewing the cases we had, there was, following repair with native esophagus, some 80% had stenosis and had a widely dilated, almost all of them had a widely dilated upper esophageal pouch. And a large number of them had a big to small anastomosis. And as you can see here, it is like a funnel. It collects saliva and liquid foods, and solids are often blocked, and many would have come with meat to be extracted because it is causing blockage. So esophageal reconstruction with native esophagus is fine as long as you do not end up with serious consequences such as these. And when in a neonate you have this situation, the child is lying down, you get reflux into the pharynx with aspiration and repeated lung problems and markedly damaged lungs. And that's for a lifetime. So slowly but surely, I began to try to apply the principles that I had learned here to try to resolve these concerns. A large, wide pouch leads to a funnel effect. Therefore, it needs reduction. Therefore, I tried to develop the upper pouch esophageal, fully vascularized flap, taking out a large, long, wide, approximately half the diameter of the upper pouch, taking out a flap from the upper pouch and turning it down. This allows me to close the esophagus and to reduce its diameter, and then to insert it into the opened out lower pouch so that I get an esophagus which is wide, which is with a long, wide oblique anastomosis, not a round circular one that tends to stenose, and therefore an esophagus of more uniform diameter. So this became my routine practice. I started as a consultant in '84 and up to 2005, and then recently I have done some more in other countries. We have, the numbers are not great. We had 58 patients. There was no mortality. There was no morbidity in 35 patients. These were the latter 35, because in the first ones, there was an incidence of an anastomotic leakage, but one has to learn when one attempts something different. It's not an excuse, but it happens. So what happened with the anastomotic leaks? There were 9 of them. We just left a chest drain for a little bit longer. It closed spontaneously, and they never had stenosis, and they never had dilatations, and even today continue to eat without problem all foods. Never came back to hospital except for just routine follow-up. Recurrent toughs, we had 5. 1 required a redo, and I interposed an intercostal muscle flap between the trachea and the esophagus, and it healed without problem. And 4, I did a replacement with something else. Later morbidity, there were 2 stenoses, and we just redid the anastomosis. dysmotility, in other words, slow passage with retention above the anastomosis, but not a stenosis. There was 2 children who would occasionally have some bolus of foods getting stuck, and they would come and have them removed, but they never came to further surgery. 5 had gastroesophageal reflux, 3 were treated only medically, and this eventually cleared up as they grew. And for 2, we did fundoplication, of which I used to do a Nissen. All of these children today, years and years later, eat an unrestricted normal diet. And the nice thing about it is they didn't have dilatations, and they didn't have to come to hospital repeatedly, except as an outpatient follow-up. Okay, so I know it's a long day, and so I want to get on, and I'm not going to give you a lot of statistics because unlike that beautiful paper by Dr. Maffei, because I'm not that intelligent and bright, I have to tell you. So what is long gap? We all talk about long gap, but what is long gap? What do we mean when we say long gap? So here, look, this I think is obvious, long gap. There are some 10 vertebral bodies here. Okay, so the operative pediatric surgical textbook by Louis Spitz and Arnold Corrin tells us that the average gap in the average type of esophageal atresia that we see, 86.5% is type C, is of about 2 to 3 vertebral bodies. That's not long gap. You can deal with that without any great problem. I deal with it using the esophageal flap for the reasons I gave, but whatever. As long as you don't have complications, that's fine. Beware of the child who presents to you with a fistula at the carina, because very often the upper pouch is also very short, much shorter than on this picture here, and the gap is longer, so there is going to be quite marked tension at your anastomosis. But then from what we have heard, tension maybe is a good thing. It hasn't been in my hands, I have to tell you. Okay, my definition of long gap is not based on distances and such like. It's whenever I cannot reconstruct to a normally functional esophagus that allows the patient to eat without problem, with a wide tension-free primary anastomosis, so that the patient doesn't have 2, 3, 5 thoracotomies and great numbers of dilatations, and which does not have any reflux or hiatus hernia, does not require fundoplication. So if I cannot achieve this by my routine method, then it falls into this group which, if you like, I can classify as similar to long gap, because the problem is the same. Lengthening procedures. Clearly, one wishes to save the native esophagus if possible. And I have said to you, I use my flap, and with that I have been able to bridge up to 4 vertebral bodies. Beyond that, it starts to get tight and much more difficult. So my average is 4 vertebral bodies. I can use part of this flap, if I take it wider from here and longer, to actually elongate by a couple of centimeters the upper pouch to reach the lower pouch, and that also works well. So elongation techniques in this sort of manner have helped me. You have shown us tension, either external or internal, as per the Fokker. That seems to help. This has been my method, because when I spoke with Fokker, I was not convinced, and I tried on one occasion and I didn't like it. The Kimura technique is you know about. You create an esophagostomy and then you step it down the chest. The problem with it is that you are sometimes able to elongate, but the elongated segment is usually very firm and fibrotic, and very often and aperistaltic, and very often creates resistance to passage and difficulty with eating. So I tried it a couple of times, but it didn't help me. I spoke with John Fokker because he said to me that 10 days of pulling on the esophagus leads to new growth of esophagus. It's very difficult to accept that in 10 days, an esophagus grows new tissue sufficient to cross the chest. And I looked at his cases and I didn't like the fact that they all were very short with the stomach in the chest, apart from the stenosis, but all requiring fundoplication. And I asked John Fokker, if you are saying that by pulling on the esophagus, it grows, why do you stop pulling it? Why do you not continue pulling it until you get a full length without the stomach in the chest, without reflux and the need for fundoplication? He said, well, 10 days of being paralyzed on a ventilator is long enough for a child. It becomes dangerous after that. But that's not a reason from an esophageal point of view. Maybe 15 days would have been better if you are really growing. I don't believe that the esophagus grows. I believe that you stretch the tissues and you pull the stomach into the chest. Another interesting concept was that of Hardy Hendren in the 70s, who attempted magnetic traction. He used to put metal bits in the upper and lower pouch, pass these children through a large magnetron machine that magnetized the metal bits, and they attracted towards each other. This was interesting, but didn't take on because who had magnetrons all over the place? So it sort of died. Recently, Piero Bagolan from Rome presented some information regarding magnetic traction again. I find it very interesting. I have tried to contact him to get some more information in relation to the extent of the gap that can be crossed this way. Does the esophagus grow? You can take much longer time than 10 days because the child is not on a ventilator and does not require repeated surgeries, as I understand it. And so for what length of time? But I have not been successful. I would have liked to have, with his permission, presented you some information. I believe that there is something here that is worth following up. Okay, so I agree entirely that the best tissue for esophageal reconstruction is the native esophagus, as long as it allows easy oral eating at the right time, very early on, for brain learning, to avoid food phobia and such like, does not lead to aspiration and lung injury, and there is no gastroesophageal reflux. If you cannot achieve that, then to my mind, my conclusion over my career has been, it is better to abandon a poor dysfunctional native esophagus. You see here a funnel effect from big to small, a stomach pulled up into the chest, and reflux. Better to abandon a dysfunctional esophagus needing fundos and such like that also end up in the chest, and better to have a functional other esophagus made from something else. So here is this child, for example, with this huge gap along the way there. And the principles remain the same. Neonatal physiology must guide our reconstruction. So we need to find a way to feed the child early in order for him to develop his brain and to avoid food phobia. So for me, I know Olivier said never an esophagostomy. It is the work of the devil. Well, I'm a devil, I have to say. So for me, a wide right side, not left side, that was historical. And there was reasons for that, but they don't exist anymore. So a right, wide esophagostomy, very wide, sufficient to allow the child to feed by bottle in the normal way, normal rate, normal timing. And then you collect what comes out from the esophagostomy in a bag system, just as you would for a colostomy and similar, and you feed it down into the stomach through a gastrostomy. And my colleague from Brescia has taken on also the concept of aesthetics. And he sent me this picture last week. And you see, he has approached his gastrostomy through a periumbilical incision where the scar will fade within a natural skin crease. Great stuff. There is no place for techniques that delay oral feeding. Delayed repairs lead to brain problems for the long term. Okay, so what would I replace with? Well, my preference, unlike everyone else's in the room, is for jejunum. I believe that the jejunum raised in an isoperistaltic manner is anti-reflux. Also, it continues to peristalse freely and easily. I pass it through the hiatus and through the posterior mediastinum. It can, because it is anti-reflux, it can be done very early, so it fits in with brain learning. And so far, from the few cases that I have done, there have not been long-term problems. So this is a two-stage procedure at this point. The first stage was to raise the jejunum, and there is no loss of tissue here. This is the first part of the jejunum, some 10 centimeters beyond the duodenum. You divide the vessels and the blood supply is coming from below, and you, in a two-stage procedure, you leave it for some 6 weeks, and that strengthens the mesenteric supply. And here you see, just before we're going to pass it through into the neck. I didn't put all my slides because I thought I would not have sufficient time, and I'm sorry now, but anyway. So here is this jejunum, and you see it is lying there with contrast in it, and here is the child. And I will defy anyone to tell me that this child doesn't eat well. She has never had any problems. She has never had any dilatations of any sort, and there is her jejunum. The difficulty with jejunum is that the blood supply is rather more delicate than other tissues, than other replacements. So whenever I approach a child with the intention of doing a jejunal loop through the posterior mediastinum, I always tell the parents that if I am not happy with the blood supply, I will change. And my next change is for a total stomach. You see, even after a gastrostomy and feeding and reflux and whatever else into the lower pouch, you see how small this lower pouch has remained. It's difficult for me to accept that this bit of tissue grows sufficiently to cross the whole chest. But I accept what I hear from other people with interest. I'm not sure whether it would yet change my view, but I'm open to persuasion. So here is a total stomach mobilized on the vessels. Obviously, you have to do a pyloroplasty as well, and you take up the fundus through the posterior mediastinum, and here it is. And if I haven't got a stomach available for whatever reason, then my last fallback is an isoperistaltic colon based on the left colic vessels, as you have seen today, but always through the hiatus and the posterior mediastinum. Far shorter lengths, distance to travel, and much neater. And also there is no kinking in the neck, which is where a lot of problems arise with swallowing food. The problem with the stomach and with the colon, although they have a reliable blood supply, is that they void by gravity. although we have heard today that they perform some peristalsis, but on average, practically speaking, they void by gravity. So it is important that you have a child who is able to sit up erect for at least half an hour on his own, not just placed in a chair in which he slides into a supine position, but sit up erect for the stomach and the colon to empty of food and not to reflux into the pharynx and have aspiration. So between 84 and 2021, I was involved with 72 patients with a follow-up that extends through to some 37 years now. I started my career doing what I was taught, which is a transverse colon, initially retrosternally for a couple, but then rapidly through the posterior mediastinum. Of these 11, there was no mortality. 2 out of 11 had a cervical stenosis, which was not difficult to revise, but they did require further surgery. Okay, so the next phase, I then moved, after discussions with Louis Spitz, quite rapidly towards total gastric transposition, of which I have been involved with 36 cases. 3 of the 36 developed a transient dumping syndrome, which settled spontaneously, but for whatever reason, which I don't understand, 1 recurred at 14 years of age and requires dietary adjustments. 1 child had a cervical stenosis, which we revised, and another child developed severe gastric dilatation because he had poor lungs and he would air swallow, and he would fill his stomach with air, compress it and collapse his right lung and get into problems. I did a thoracotomy and trimmed the stomach down to more appropriate size, and he has never had trouble since. In this group, there were 4 deaths, 1 from congenital heart disease, 1 from Klebsiella septicemia, and 2, and I learned a big lesson here, was that for both colon and stomach, it is not possible to do them before the child is able to sit up erect, because these children aspirated refluxed food from the stomach and colon into the pharynx. These were stomachs, actually. But it's the same for colon. So my conclusion was that delayed reconstruction had to wait until the child was able to sit up. You could not do stomach or colon before the child was able to sit up spontaneously for at least half an hour. This did not fit with the principles that I was trying to, and the concepts that I was trying to follow from the point of view of physiology and early feeding and such like. So I moved towards developing the jejunal interposition as a substitute for the esophagus. And we have done now 25 cases, 7 as a 2-stage procedure, and then subsequently, following experience in Italy with colleagues there, I started to do a 1-stage procedure whenever possible. So out of the 25, we had 1 stenosis, and in the cervical area, the anastomosis, simple revision, no problem. 1 loop necrosis completely, and I just replaced the thing with the stomach. Obviously, this related to blood supply. And then on 3 occasions, I did not feel happy with the loop. And so on table, I converted and put stomach instead. And in 1 patient, I used colon, always posterior mediastinum. There was thankfully no mortality. All of these children eat unrestricted normal diets, as I have attempted to show you previously. In conclusion, then, my feeling and my conclusion is that we should respect that which the children require of us, not tell them what we feel we want to do for them. And if you ask a child, he wants to breathe freely, doesn't want problems with his lungs. He wants to swallow easily and grow normally. And then if you ask him and he's honest, he will tell you he doesn't want ever to come to hospital or see your face again. What is important for these children is quality of life. So here are two jejunums. This is the young lady I showed you early on with a plate of food in front of her. This is another Greek child who is now actually 19 years of age. There is the jejunal interposition. So the children do not ask to have a native esophagus at all costs. What they want is quality of life, the ability to eat, to enjoy their food, and preferably to have an aesthetic body. In 1959, there was a report on the needs of children and the Platt report, and it said greater attention needs to be paid to the emotional and mental needs of the child. We should learn to listen to the children, ask the children what it is they want of us, and then have the courage to change. Thank you for listening to me.
One, Mr. Senior Chairman.
Right, so that's my bit.
Thank you very much, Adrian. I think it was a very comprehensive view of all the problem, and always with your personal and very convincing ways of thinking about the different problems in pediatric surgery. So
I don't know about the convincing.
Oh, well, you are always contributing very good ideas to everything. So let's open discussion if someone wants to make comments or something about your presentation. Yeah, Massimo.
Adrian, compliments for having shared with us your experience. I think that life of a surgeon is should have an example in your life. And well, you know that I acknowledge you of a great experience and quality. And I want to, because of that, I want to ask you a very simple and I would say naive question. You showed us that you have done 11 transverse colon transposition, and in those 11 cases, you have 2 stenosis that you treated. Then the question is, why do you, I mean, this is good results. Why do you change technique?
Because what I had seen from my predecessor, who was an excellent surgeon and a great teacher and a second father to me, so I had great respect for him. What I had seen was beautiful technique, but when I followed the children that he had done, they began to come along, and when they were eating, they were going like this because the food was sticking in their necks.
Yeah.
And then I, from the retrosternals, and then I moved to the, and in experience, my anastomosis and blood supply was probably not so good. And then I spoke to Louis Spitz, who was older than me, and he said to me, I am professor at Great Ormond Street. I do total stomach transposition, superb operation. So I went and I started doing total stomach, and I had 2 deaths. And then the third one, I did 3. The third one didn't die because he stenosed.
So what you are saying us is the message is it's not only a problem of a beautiful technique, the study of the early complication, but even the long-term follow-up of the patient can change your mind.
Yes, and I was searching also for what is best for the children, because I began to think to myself, this can't be right, that you cannot get the children operated early. They have to wait 8 months, 1 year, 2 years. It is difficult for the families as well. So my feelings began, what can I do to see if I can get the children repaired in a safe manner as early as possible? Stomachs were very good, but if the child is sitting up. Colon, the elongation, the halitosis sometimes, I preferred the stomach. But then I thought, why not the jejunum? So I tried one jejunum and it was looking beautiful, and then I passed it and it was looking blue. And that put me off 3 years. And then one day I had microgastria, and the child had diarrhea for no obvious reason. So no stomach, colon, question mark. So I said, I tried the jejunum again, and it worked, 2-stage. So we started to do jejunum because it is beautifully isoperistaltic. They don't reflux,
because it's,
and they eat beautifully, but it's more difficult.
Yeah, I agree. I agree.
Thank you.
Thank you.
any further questions? Then thank you very much.
Adrian, I fully agree with the jejunum. That is a fascinating topic, but you are the master, of course, of the blood supply, splitting clothes and doing the Bianchis and whatever else. To your knowledge, who else is doing that in Europe? Where could you turn to learn it?
I don't think anyone is very interested in jejunum, really.
Yeah, the Dutch were interested. Yeah.
Yes, but not in the same manner. The trouble with the Dutch procedure, Van der
David is doing it, I think, or used to do it.
Yes, but the way they used to do it was the way that was shown on the previous pictures, I think from Olivier, where you took a piece of jejunum, you cut out a lot of to get a long. I don't do that. I just take the jejunum from below the duodenum and raise that first part.
Okay.
Okay.
So you don't create a pedicle like David did.
No, then that way I don't sacrifice any small bowel. Okay. It's only that loop, which is about 40 centimeters, 30 centimeters.
Stefan?
So,
actually, I have performed the jejunal interposition with David. So exactly like Oliver showed in the slide earlier today. So with a vascular graft, not the supercharged like they would do in Boston. But since we started traction sutures, so that was 15 years ago, we haven't performed any jejunal interposition anymore.
Yes, because then it coincided, to finish answering the question, it coincided with the time of thoracoscopy, laparoscopy, thoracoscopy, and all the interest went that way.
Thanks.
Okay. Should we move to the next presentation?
Absolutely.
Thank you very much, Adrian. Thank you very much. As usual, we enjoy your talks.
Pleasure. Thank you.
Thank you. So, what is next?
Giovanna should be next. Back to the program.
So I think I am ready. No, just a minute. I try to share my screen. And what is, oh, this is PowerPoint. Okay. Condividi. Okay. And then, could you see my screen?
Yes.
Okay. Okay. So, oh, sorry, I am at the back of the presentation, not the beginning. Okay, this is the first slide. So I tried to do shortly, but this is a very, I mean, challenge case, very, also very complicated. It's a case of a patient with caustic lesion who underwent to a laparoscopic transhiatal colonic transposition, but it was not really a complication of the technique, but a complication of the caustic lesion. This patient was born in 2004 in Sierra Leone, and at the age of 5 years, he had a caustic injection with severe injuries to the upper GI and also of the respiratory tract. So a gastrostomy tube was put in place immediately. Then he was transferred to Italy, where a tracheostomy was performed in another institution. I received this patient in 2012 at Bussi Children's Hospital in Milan, and I tried to study all the aspects of the disease. And first of all, I tried to do a CT scan, and the CT scan, there was no esophageal lumen was detected. There were obviously some bronchopulmonary consolidation and bronchiectasis at the lower and middle right lobe. We performed an endoscopy, and unfortunately, I have not all the picture because it was several years ago in another hospital. And we found the presence of severe occluding pharyngeal synechia, this almost the same picture that Olivier showed before, and they were treated with laser CO2. Then we did a transgastrostomy endoscopy, and the cardiac adytus was completely closed. And then we did several sections of laser treatment to try to open the pharyngeal synechia that were occluding the glotting area and the esophageal adytus. At the end, Professor Narne from Padua, he was a very expert and performed a lateral cervical pharyngostomy. So I did a complete study to assess the stomach, the bowel, the colonic condition. And then during this, in the meantime, I went to visit Olivier and looking to his technique of transhiatal video-assisted esophagectomy and colonic transposition or gastric tube in the posterior mediastinum. So in this patient, I did the same technique. This picture looks quite similar to the picture that Olivier showed before. So we did a laparoscopic transhiatal video-assisted esophagectomy, and then a reconstruction with the colon, because due to the previous gastrostomy, the stomach was not available in this patient. I did another case where I constructed a gastric tube, but in this patient I was obliged to use the transverse right colon, isoperistaltic, using a middle colonic artery as main vessel, because it was the best vessel that he had. At the end, I performed also this anti-reflux wrap in the same way that Olivier has shown us. These were the tube, the same tube that he showed before, one for jejunal feeding and another one for draining the colon. So that were the phase. I had a laparoscopic phase of transhiatal esophagectomy, a cervical phase on the left side, then an open abdominal surgery to perform the transhiatal esophagectomy, the colonic preparation, the cologastric anastomosis, pyloroplastic, anti-reflux surgery, and PEG, and then cervical phase, where I did a very high anastomosis, a colopharyngeal anastomosis. This patient had, I have to say, further treatment during the following year of the synechia. We were obliged to do also dilatation of a colopharyngeal anastomosis, but I have to say we were not really in trouble with the colopharyngeal anastomosis. The problem were the synechia up to our anastomosis. So I invited Professor Monnier. In this patient, we placed ammonia stents through the glottal plane, because this patient has not good vocal cord. And then we did several endoscopies to treat always the recurrent synechia in the airways. And in 2014, the Monnier stent were removed, and a catheter trachea cannula was placed. Then this patient went to visit in Lausanne Professor Sandou. He did a reconstruction of the posterior pharyngeal wall in order to avoid the recurrence of the occlusion of the pharyngeal. Then he went to Bambino Gesù and he started a long rehabilitation, but this rehabilitation was also unsuccessful. And the final decision and advice, also the final decision of the child, was to prefer the oral feeding, renouncing to a better vocalization. But this patient had several inhalation, so this patient had again the placement of the LT mode. Then I lost any information about this child. In October of last year, he went again to visit Professor Sandou in Lausanne. He wrote me that he removed the LT mode and the esophageal conduit, in his opinion, at that time, had a good looking, a good appearance. The child went back home, and unfortunately, he had bilateral bronchopneumonic accident. So I invited the people who had this patient on charge to put a catheter cannula and to stop the oral feeding and to move to a PEG feeding. He did this, they followed this advice, but in January, this patient started to vomit immediately after PEG feeding. He lost some weight, and I accepted to this patient who is now about 18 years old in my institution in Pavia. We have a transitional care program, and I found this patient in very bad nutritional condition, and we put under parenteral nutrition with a central line. And I started to study this patient, and I need to have also your advice on this patient. So we did first a trans-PEG GI study. We saw a reflux in the colon, but we were not able to understand this picture on the right side. I thought it was colon. At the end, it was the wrap of the stomach. And I thought that I was obliged to redo the gastric anastomosis. I did also a study from above, and the colon looked quite well, not so redundant as I thought. So we put but we found, I moved to another, we performed a complete endoscopic study. And this was a study from above where we found on the, I go back just a minute, we found on the left side, the gastric, the colonic transplant, and on the right side, the airway with the cannula in place. But performing through the PEG, the endoscopy, we found enteric material in the stomach. I have done other endoscopy in this patient previously, the year before, and I have never found enteric content. So I thought there was no duodenal obstruction. So we decided to put a JPEG, and then we did a study. So the JPEG, we found this dilatation of the proximal jejunum. So we thought that this patient has some adhesion and maybe some trouble at the cologastric previous anastomosis. So we moved to surgery, It was an open surgery, obviously, and I will have a short video. And we found this situation. First of all, the peg, the patient had the peg 10 years before. So this peg stretched a little bit the stomach. And I found that the junction between the colon and the greater curvature, so the distance between the lesser and the greater curvature of the stomach was quite short, in my opinion. The stomach was stretched from the peg. Oh, excuse me. And I am doing some confusion. And the previous anti-reflux wrap was responsible of a slight compression on the colonic transplant. Obviously, there were a lot of adhesion. We passed a longer time to release this adhesion, but then I tried to go faster. This is the opening of the stomach at this level. And I didn't find any trouble in the colonic transposition. And we passed through the colon a tube. This was a jejunal tube that I used. I put also down in the jejunum to accomplish a jejunal feeding, and I left another tube inside the stomach. I tried to go a little bit quickly. This is the first tube inside the jejunum, and the other tube was left in the stomach. At the end, I tried to feed all the stomach, and I did a sort of reconstruction of the stomach cavity in order to have more distance between the cologastric anastomosis and the greater curvature, and to give more capacity also to the stomach, and to accomplish a better nutrition. And my hope is to be able to go back to an oral nutrition in this patient. At the end, we reconstruct again, obviously, the gastrostomy. Okay. So, but what I want to discuss with you is that I hope after this release of adhesion, reconstruction of the anatomy, to give the opportunity to have an oral feeding and maybe a mixed oral PEG feeding in this patient. But the main problem remained the inhalation in the airways. After 10 years, in Italy and also abroad, we were not able to avoid inhalation in the airways in this patient. So what to do? I discussed with our ant specialists. They are very qualified, and they suggest, according to the story of the patient, to perform a pharyngectomy, to placing a vocal prosthesis, as they used to do for pharyngeal tumor, and leaving the patient in oral feeding. I presented this patient also to know your advice, maybe the advice of one who is really an expert in this field, and of other people of the faculty, and to know what is your advice, if you agree that in this patient it could be better to give him the opportunity to eat by mouth. He would like to eat by mouth, and to leave the airway to another, another solution, because after 10 years of competent procedures made by expert and surgeon, we are at this phase. Thank you very much for your attention.
Thank you very much, Giovanna. The good thing of being retired is that you do not have to deal anymore with these things. I think this is a terrible case, and I agree with you. Probably it will be much better if you privilege the eating activity above the vocalization. So probably I will do as you suggested. Yeah.
Someone of you has experience of such a terrible case?
No.
Adrian, Mario?
Well, I have experience of one, but it's we had to stop halfway because of COVID, so I can't give you an answer yet. Maybe I missed it, but can you tell me were the vocal cords functional and intact here?
No, they were not intact. They were not intact. You know, Professor Monnier treated this patient personally. I invited him in Milan. Then Kishore Sandhu did sample. Oh, Olivier, please.
So sorry.
Olivier is here. I would like to hear his opinion.
Well,
Olivier.
Adrian asked the only question, whether the vocal cords are intact or not. And I've said, when I show you this procedure we did with Philippe Monnier and now Kishore Sandhu, we can do this if the vocal cords are intact, because they learn how to swallow closing their vocal cords. Yes. If you have a paralysis of the vocal cord, I don't believe that you can expect an improvement. So my belief is that you have several ways, but they're all, how to say, second choice. So the first one is to leave Monnier mold in the larynx. The Monnier mold is in silicone. It has to be replaced, and it avoids a lot of aspiration if the child has no vocal cords, because it occludes the larynx. Sorry. And you can put a tracheostomy below. And our experience with Philippe Monnier and myself is, with a Monnier mold, they can swallow as far as they don't aspirate.
Yes, it was also the experience of this child. This child has a terrible story because he went in different places, also in Italy. But the problem is that we put the LT mode with Professor Monnier, and he had no aspiration at all. The problem started when someone took away the LT mode. And now after the last procedure that I did, because he had obviously an obstruction, intestinal obstruction, and enteric material in the wall column. So that was not the observation made also a few months ago. So I would like to put immediately the LT mode again, because waiting maybe for the final decision, because if the vocal cord, I am not an aunt, but I have seen this patient several times through the years, and I have never seen the normal vocal cord in this patient. So I think that the discussion is between leaving LT mode in place and changing periodically, or performing a laryngectomy. But I always hesitated.
That's exactly the choice, Giovanna. That's exactly the choice. After 10 years, the recovery of the vocal cords seems very, very low. So you have just the choice you've said. Either you put a LT mold and then you change it regularly, waiting for an hypothetical improvement or a new technique or something else, or you choose for a definitive laryngectomy. But I'm not even sure that with a laryngectomy, you will solve totally the problem. So
I agree with you. I will put,
I would choose the LT mode because it's not a definitive solution.
yes, it was always my choice. When I was in charge of this patient, I also tried to avoid the laryngectomy. First of all, because it was a child, and second, because he was doing well with LT mode, and third, because maybe there is something new in the future that can give him the opportunity to have a better results. I have to say that Professor Monnier was of this advice. I have to discuss again with Sandhu, with Kishore, because he took it away, suggesting a rehabilitation, but the rehabilitation was completely unsuccessful. So I was obliged to put a catheter, cannula, and I don't like to leave in place longer cannula. I prefer to put again LT mode. Michele Toller has something to say. Thank you very much for all your contribution to this poor guy.
Thank you.
Hello, Giovanna. It's a very difficult case. We have had similar cases in whom we advised to leave a cuffed cannula and to eat with the cuffed cannula. Yes, you're right. Cuffed cannula is not an ideal solution, but has the advantage that if the patient wants to speak, she can do by the cuffing the cannula, and there is no life-threatening problems if the cannula is blocked. The LT can happen, but the LT mold can also be more dangerous because there is no possibility to intubate the patient from above. I don't know. So maybe cuffed cannula can be the simplest solution if the cuff is not very full, very cuffed, and so it cannot damage the trachea.
I have to say that the patient had no trouble with the LT mode. And I have seen that the LT Professor Monnier fixed, and also Sandhu, they fixed the LT mode in order to avoid with a not resolvable stitch, in order not to have a displacement. And this patient was quite satisfied with this device. Now I put a cuff, a cuffed stand, but I think before taking a decision, I will discuss. Mario says that we have to go on because it's late. So I thank you, all of you for your contribution. I stopped my discussion.
Thank you very much, Giovanna. I think we have 1 hour to go, and we have still a number of speakers. Who will be first? Because I'm a little lost in the program now. We are not following the order. Who should be?
Girolamo, perhaps.
Girolamo.
Is still there?
Girolamo is not here. Maybe I have to present his video.
Okay.
Go ahead, Michele.
Yes.
Yes.
I'm in emergency department, so I hope no one is coming. Okay. It will be very fast. It's just a video of a patient. Should be this. Can you see it?
Yes.
Yeah, we can see.
So just two words about the patient. Is a patient coming from another country, 3-year-old, and long gap esophageal atresia, who had an history little strange because he had we don't have a very nice history, just a few few news, but not very understandable, because he didn't have any thoracotomy until 6 months of age. He had closure of the fistula by the abdomen and gastrostomy, and they wait for 2 months, and then they put cervicostomy. And at 5 months, because of respiratory problems, very severe, he had to perform a tracheotomy and then removal of mediastinal cysts behind the trachea that we suspect it was the remnant of the fistula that was ligated very low, just above the stomach. I don't know. We are not sure about that history, but could be like this. So then they had to perform esophageal replacement, but for the COVID they didn't do. And finally the patient came to us. We studied, and there was practically no esophagus from the stomach. We couldn't even see the cardias. And the cervicostomy was the cervical esophagostomy was very high. So this is the video Girolamo gave to me to show how from below, sorry, Professor Reinberg, because we did all many of the things you suggested not to do, as the gastric pull-up and using harmonic scalpel, but you can see from below the transhiatal dissection, the aorta, and we try to stay into mediastinum, and we manage for some time, but after upper in the thorax, we opened accidentally the pleura, and so we went on until the apex of the thorax from in the pleural cavity. Here you can see these vessels are, this is the vertebral artery, and the lower one there is a subclavian artery, and here there is also the carotid artery. This was studied with CT angioscan, CT with contrast before the surgery, and he had a lot of vascular anomaly, also left vena cava. Here we cut the pleura not to have an angle, and the position of the stomach was behind the hilum, the lung hilum. And okay, the video is over. I think that with this approach from the abdomen is very, as Professor Reinberg also showed before, is quite easy and very nice to see and straightforward to join the neck. Thank you.
Okay. Yeah, I think I have a comment on the opening of the pleura. I think this is not very good for the gastric transposition thing, because in fact, when you put the stomach into the pleural cavity, negative pressure contributes to dilate it more than if it remains into the retromediastinal space without opening the pleura. So this should be, if possible, avoided, in my opinion. Yeah.
Sorry, I forgot to say that we performed a pyloroplasty, of course, and the closure of a gastrostomy, and we performed a jejunostomy. Now the child is about 3 weeks from the surgery. The stomach is compressing the lung effectively, but is breathing very well. He doesn't have any need of oxygen. We are quite concerned about the lung in the future because the stomach is compressing, and we are trying to do physiotherapy, and he has a tracheostomy still. Actually, he doesn't have any tracheal stenosis or laryngeal stenosis, so we plan to remove tracheostomy later, but now we can use it for some physiotherapy and maybe nocturnal ventilation to have more lung ventilation.
Thank you very much, Michele. Some more comments about this video and yeah, Adrian.
Can I just mention very quickly, it is absolutely essential if you drew a total stomach to do a pyloroplasty, because it is always denervated. So you don't take chances. At the time you do your stomach mobilization, you have to do a pyloroplasty. The other point I wanted to make is very interesting. We've seen it with Olivier and yourselves now. The development of the pathway from the bottom end, from the abdomen through to the neck, before you do your transposition, done laparoscopically and thoracoscopically, if you like, would be an improvement on the blind technique that I have always had to practice. So I think there's something worth pursuing there.
Yeah, I agree with that. Yeah, I agree with that. No comments.
I would like to underline an aspect of gastric transposition, not only congratulations, Michele, for this case, congratulations for the elegant technique. And I think that the mini-invasive approach is the most important, will be the most important in the future. But what I want to underline in gastric pull-up is that in my small series, is not more than 10 cases, we don't have in this patient reflux stenosis, I mean peptic stenosis, because we try to do the anastomosis up to the thorax in the neck. And because we have a lot of young people hearing also this afternoon, I think it's very important to underline this aspect. I have a lot of endoscopic control of this patient with beautiful anastomosis, very nice anastomosis. I don't know what is the opinion of Juan, who is.
Yeah, I agree with you. I agree with you. Most cases have very good anastomosis. And again, as you stressed, think the anastomosis should be in the neck, because if you have to do something, it's approachable. If you are in the middle of the mediastinum, that's a horrible thing. So I agree with you. More questions? No, thank you very much, Michele. And we move to the next presentation, if you agree. So next one will probably be Dr.
Next
Noccioli.
presentation.
Noccioli, yeah.
Buonasera, ciao. La prima parte sarà in italiano e poi seguirà la parte di Ciardini in inglese. Condivido lo schermo? Sì. Possibile.
È arrivato, perfetto, vai.
È arrivato?
Sì.
Bene. Benissimo. Dunque, la mia prima parte è quella del raccontare un attimo l'esperienza di un gruppo chirurgico, di un ospedale nel trattamento della long gap e nella sostituzione dell'esofago in caso di long gap atresia. Io ho lavorato per oltre 40 anni in un piccolo ospedale, Meyer di Firenze, un ospedale nato alla fine dell'Ottocento nella città di Firenze, in cui è sempre stata presente una chirurgia pediatrica che ha trovato però il suo riconoscimento oltre 60 anni fa con il primo successo nel trattamento dell'atresia dell'esofago ad opera del professor Carlo Alberto Montagnani. Dopo di lui è stata creata una cattedra di insegnamento, sempre dipendente dalla chirurgia generale, ma l'università capì che la chirurgia pediatrica cominciava a essere una materia degna di una certa autonomia. Sono voluti altri 20 anni, ma comunque poi la strada era stata intrapresa. Io ho avuto la fortuna di entrare molto giovane in questo ospedale, grazie al successore del professor Montagnani, il professor Pampaloni, che mi ha coinvolto molto nell'attività di chirurgia toracica e dell'esofago. E in questo periodo di tempo in cui sono stato in ospedale, io ho potuto seguire, essere coinvolto in prima persona o in equipe su 347 neonati operati per atresia dell'esofago. Così vedete numeri percentuali corrispondono alle esperienze di qualunque centro nazionale o internazionale. I numeri sono piuttosto piccoli perché la città non è una grande città e la natalità della regione è bassa. Comunque il nostro argomento riguarda la long gap e di questi diventano 321 perché le fistole esofago-tracheali ad H le avevo escluse e vedete le percentuali variano dal 100% e così a calare nelle varie forme di atresia. Quando è stata necessaria la chirurgia di sostituzione? In circa il 50% dei casi nella nostra esperienza. E vedete in che percentuali rispetto alle diverse forme anatomiche. E che tecniche però in questo vasto arco di tempo sono state impiegate. Dovete considerare che i primissimi anni in cui ho lavorato, i primi 3 anni, l'ospedale non aveva cure intensive. Quindi il neonato veniva operato d'urgenza. E i vecchi chirurghi eseguivano la toracizzazione gastrica nelle forme in cui era impossibile eseguire un'anastomosi primaria normale, esofago-esofagea. Difficilmente, in pochi casi, veniva eseguita una esofago-colon-plastica tipo Waterston. Nell'epoca alcuni sono stati direttamente indirizzati a Bologna dal professor Domini, che aveva iniziato l'attività chirurgica in questo settore. Ma nel periodo successivo, dall'82 al 2003, si è invece seguito la strada della colonplastica retroesternale tra i 7 e i 10 kg di peso, con o senza esofagostomia cervicale. E questo quindi per un lungo periodo di tempo. Dal 2004 in poi, invece, questo si sa dell'intervento, dal 2004 in poi abbiamo pensato però, seguendo un po' quelle che erano le indicazioni internazionali, a preservare l'esofago nativo. Perché anche, come diceva Adrian prima, il miglior sostituto dell'esofago è l'esofago stesso. E quindi abbiamo seguito i criteri di tutti. Non abbiamo mai fatto trazione sui monconi, una trazione intratoracica o extratoracica. Abbiamo seguito la linea di conservativa, osservare l'allungamento spontaneo dei monconi e se il gap in un lasso di tempo di 8-10 settimane era superiore ai 4 corpi vertebrali, si metteva in programma una sostituzione dell'esofago mediante esofago-colonplastica. Diverso poi il problema dell'evoluzione, perché dal 2000-2002 in poi l'ospedale si è fortemente rafforzato nelle professionalità e nei servizi perché ci dovevamo trasferire in una nuova struttura. E quindi l'ospedale così fatto e così dotato ha creato una afferenza di maggiore complessità casistica. Tanto è vero che in questo periodo abbiamo avuto long gap con, vedete, questa serie di difetti associati piuttosto complessi per anche la prognosi quad vitam. Malgrado tutto questo, però, vi volevo far vedere quello che ho vissuto, quello che abbiamo vissuto in gruppo, cioè, vedete, il primo periodo in cui non c'era cure intensive, 31% di mortalità. Aperto nell'84 le cure intensive pediatriche, la mortalità cala al 7,5%. Nel 95 io assumo la responsabilità come struttura semplice della chirurgia neonatale e decido di spostare i neonati chirurgici in neonatologia. La mortalità crolla all'1,8% e dal 2004 fino ad oggi la mortalità per atresia dell'esofago in tutte le sue varie forme è stata pari allo 0%. Inoltre, avendo aumentato l'attrattiva e la complessità dei servizi, abbiamo ricevuto anche 12 casi di long gap in questo periodo ultimo, già trattati in altri centri, quindi casi più complessi in cui erano state eseguite, vedete, queste varie forme di trattamenti e che avevano avuto esiti non positivi. Importante per il fatto che questi casi complessi avevano con una certa frequenza anche interventi cardiochirurgici già eseguiti, quindi pazienti portatori di sternotomia. E la sternotomia ci rendeva impossibile il passaggio retrosternale e siamo dovuti tornare indietro, siamo dovuti tornare alla tecnica tradizionale originaria di Waterston, la mediastinica posteriore, e abbiamo fatto il primo caso, è andato bene, però non siamo stati perfettamente convinti di questo, vista la complessità dell'intervento, la lunghezza e così via. E tutti quanti insieme, il gruppo della chirurgia neonatale dell'epoca, si è riunito e abbiamo deciso di seguire sì questa tecnica, ma usufruendo di quelli che potevano essere i mezzi tecnici chirurgici più attuali. Per cui abbiamo utilizzato la tecnica di interposizione colica e trasposizione colica video assistita e se ne è occupato direttamente come operatore il dottor Ciardini, che adesso non è più a Firenze ma si trova a fare il direttore a Trento, e a cui ho sempre demandato la parte video chirurgica, a cui io passo la parola perché così ci parlerà della tecnica.
Grazie.
Thank you, Bruno. I'm trying to share my screen with you.
Bene, vai.
Can you see my screen?
Not yet.
No.
Yeah.
Dovresti esserci, sì. Vai.
Ok, vai.
Okay.
Here we are.
Yes,
Yeah.
we see.
Good afternoon to everybody. It's quite hard to me to speak after this series of colleagues that have so big experience that they decide to share with us, but I'll try to do my best. I'm talking to you of our experience with two patients we had a variation in the classic technique of colon interposition. And we use a technique that was thoracoscopic assisted. We treated two patients, one 15-month-old girl and one other patient, 8-year-old, that for different reasons were scheduled for esophagocoloplastic. Both of them had, for different reasons, previous sternotomy. So in both cases that we found that a direct anastomosis was impossible, and we decided that the substitution of the esophagus was necessary. For us, as Dr. Niccioli said before, our first choice for esophageal replacement usually is the retrosternally way. But in these patients, it was not suitable because of previous sternotomy. So we decided to place the graft via an intrathoracic route, Waterston way, by the passage of the colic graft into the chest was performed thoracoscopically assisted. We placed the patients in supine position with the left hemithorax slightly relieved, and we use for both patients 3 pores an optical 5mm port placed in the medial axillary line with a 30 degrees rigid thoracoscope and 2 3mm port in the first patient of lower weight and 5mm ports in patient 2.
placed respectively above and below the first one. We reached the paravertebral space. We opened the diaphragm on the left side of esophageal hiatus, and the pleural cupola in the retroclavicular space. Then the isolated colon segment that was mobilized retrogastric was passed through the cavity in the diaphragm and placed intrathoracic behind the left pulmonary artery branch, following the horizontal link. Next steps were proximal and distal esophagocolic anastomosis. Here are shown the passages that we will see better in the video. In the pictures above, the diaphragm was opened at the left side of esophageal hiatus under thoracoscopic vision, and in the lower pictures, the pleural cupola was identified and opened in the retroclavicular space. Both the diaphragm and pleural cupola were opened using a clamp from the abdominal cavity and from the neck too, with double maneuver from inside and from outside. Then the isolated colon segment was mobilized and put inside the chest till it can reach the cupolar player and passed into the neck. This is the video. We can see the opening with double maneuver of pleural cupola and getting a passage to the neck. And this is the opening of the diaphragm. This is the passage of the colic graft through the diaphragm and past the retrohilar side, and then put it into the neck. The esophagocolic anastomosis was performed in the neck. The follow-up of both patients is now 4 years, and we did for both patients regular clinical checks. They are both in good general conditions, and their feeding behavior is comparable to the other infants of equal in age. Thanks for your attention.
Thank you very much. These interesting and complex cases. I have to open the discussion because we don't have that much time left. So someone wants to make any comment about the presentation from Meyer and from Trento?
May I have a short question?
Of course, of course.
Enrico, congratulations, but why did you prefer to put an open instrument from above in the cervical phase rather than to go from down, down up? Because you know, here there is the most complex phase where you have the vessels, you have the subclavian vessel, and if you go looking from down to up, is less dangerous than the contrary.
Yes, Professor Issa, Joanna, the video unfortunately was not so good, and we had not too much time, but we made double maneuver, and we isolated the pleural cupola and the space, as you said, from the thorax, and it was only to have a double maneuver, a bilateral combined maneuver to have a better place to work.
Congratulations anyway. Yeah, this was a nice procedure.
Thank you very much.
Thank you very much. Any other comments? No, then no. So we move to the next presentation, Mario.
Yes, the next presentation is the last one, and is Mario Messina and Molinaro from Siena.
Okay.
Present experience of the jejunum, I think, and the gastric pull-up.
Right.
Okay, good afternoon to everybody. I share my videos. Okay.
Yes, we see your video. Okay, it's perfect.
Okay, I'm going to talk about our experience in terms of esophageal substitution regarding gastric and jejunal pull-up. And I wanna say thanks to Professor Bianchi that is here, because he's our master. With my professor Mario Messina, he teaches us the majority of principle. This kind of procedure is a major procedure and very complex surgical procedures, and he collaborated with us, realized performing the surgical procedure. We have just talked too much about the ideal conduit, that it should lead normal feeding, no respiratory compromise, does not become total red on time, minimal recurrence, not increased bilinearies, and the least but not the last, it should be reproducible. And what about native esophagus? As Mr. Bianchi says, probably is it is the best choice. But however, trying to preserve the native esophagus at any cost may be unproductive and also dangerous for the child and even for the family. Minimal invasive technique could give us some help, but not too much. And for the four most common use method are these ones that we have just talking about. Then I'm going to talk about our experience in a gastric interposition and jejunal interposition. Gastric interposition, as many part of you said, the stomach has a very good blood supply and is characterized by a rich submucosal arterial and venous plexus, which allow it to tolerate extensive mobilization on the pedicle of the great and lesser curvatural cuts. One of the best thing is there's only a single anastomosis, and probably it's simpler than the other one. Our technique is the standard technique with obviously is an open technique in which we prepare the vascularization of the stomach, sacrificing the less artery. In every case we perform a pyloroplasty, we close the gastrostomy, we remove the stomach. We used to pass the graft in the posterior mediastinal space, as you see in the videos. And I show videos of some cases. This is a case of a baby with a long gap atresia coming from another countries, and you can see some part of the surgical procedure. We remove gastrostomy, we close the gastrostomy, remove the stamp, we prepare the stomach, taking care of the vascularization, as you see, and we put at the end some stitching in order to have a good orientation of the stomach that can avoid some rotation during the pull-up, as you see in the videos. In this video, you can see the pyloroplasty, the standard pyloroplasty by Mikuliev's principle. And as I said before, we used to perform this kind of technique for all kind of a patient. I go. And this is the cervical time in which after the pull-up we prepare the esophageal stump and the cervical side. This is a very important time of the procedure because the risk of complication is higher in this area. You can see the pull-up in the postoperative in the posterior mediastinal site, and our technique is a blind technique, and I appreciate very much the technique that Rico Ciardini and Bruno Noccioli presented before me. It's a very good good choice, and this is the anastomosis in the cervical site. Okay, this is our series. We treated the six patients. The majority of were long gap atresia. This is a normal distribution between female and male. How is our postoperative management? As I said this morning, we follow this patient until 12 months. We performed an endoscopy. But we follow in a clinical evaluation for anthropometric parameter evaluation. We perform abdominal X-ray with contrast in order to see if there are some problems of stricture or something like that. This is our result. The median age of surgery in patient with esophageal atresia was 33 and more in a gastric injury. Median follow-up was 12 years, and we don't have any intraoperative complication. We have a postoperative complication, a small bowel occlusion. Regarding clinical evaluation, all patients have an oral food administration good. The anthropometric parameters was good in 3 patients. 3 patients was at the 3rd percentile. At the image, we don't have any stenosis on the and the ulceration, the regular caliber of and position of the esophagus. In our experience, it's not a big series, but the results are good. But we try to pass to using a jejunum, as Mr. Bianchi said to us, and we used to perform a technique with the pedicle jejunum interposition. It is a very difficult technique, as Mr. Bianchi said. It is a meticulous technique. It's a standard technique in which we shoot the loop of jejunum near the 10 centimeters to the ligament of Trites. And I show you a video in which I show you the technique. For the first one, we used to eliminate the stump of the remnant of the stump. We close the stomach, and then we prepare carefully the arcade, as Mr. Bianchi said, as you see in the videos. This kind of procedure, it's a procedure. Probably this is the most difficult part of the procedure. Then we make the anastomosis at the jejunum site, and we pass the stump transmesocolic and retrogastric. The stump was passed in the posterior mediastinum, and we create the anastomosis on the cervical side. show you the second part of the videos, and this is the cervical side, but it's the same of any technique. This was a case of a gastric injury of the esophageal, and the esophageal the esophagus was removed. We pass in the posterior side the graft, and we create the anastomosis on the cervical side. Okay, I go on. This was a case very complicated, in which this was a baby coming from another country, a baby who underwent many surgical procedures because of failure of the reconstruction of esophageal atresia with tracheoesophageal fistula, with the anastomotic stenosis, fistula recurrence. And he underwent multiple esophageal dilatation, 3 fistula closure, esophageal resection, 1 fundoplication, anterior fundoplication. And when he came in Siena, he was in very bad condition with the multiple pulmonitis in history. Fluid oral feeding was not so good with delayed growth. And at the abdominal X-ray, there was a stricture in the upper part of the esophagus, with an esophagus without any kind of clearance with the stomach in the chest and the fundoplication in the chest. This is some images of the gastroscopy, endoscopy to show an esophagus without any kind of clearance, with stenosis, and with the mobilization with the presence of a very big hiatal hernia with the stomach inside the chest. Then we decided to perform esophageal replacement, but in these cases the surgical procedure was more difficult, but because of the previous surgical procedure, as you see in the images, and it was very difficult to separate the stomach from the adjacent organs, and even for the passage in the thorax, we should to perform a thoracotomy in order to create the space, in order to remove the esophagus, and I show you in this is the thoracotomy, and there was many adhesions, and it was very difficult to create the space and to remove the esophagus in order to create this space for the graft. Okay, you see, we remove the ribs in order to have the space, and it continues with removing the esophagus, and in order to put the graft in the posterior diaphragm. Okay, this is our series of jejunal loop, 9 cases, median age of surgery 25 months. This is our series. The majority is esophageal atresia with a long gap. In one case is the gastric injury. We don't have any intraoperative complication. We showed a temporary vocal cord paralysis in the last one. One case is of a fistula, but closed spontaneously, and one esophageal stenosis treated by dilatation. The results are good in terms of feeding. The feeding and the growth is very good. And even for the anthropometric parameters, 7 patient now is at on 15% of growth, and the imaging not showing any problems of seizure or reflux. Then our experience is good with the jejunum and the calibrated properties, and even the conduit of feeding, oral feeding, and the growth is very good for after this kind of procedure. The disadvantage is that is a very difficult procedure, and not many times we have the possibility to create long graft in order to create an esophageal replacement. Thank you for your attention. I finish my presentation. Thank you.
Thank you very much. I think we are on time. Are there some comments or discussion of this presentation? Someone wants to discuss?
I have a comment.
Yes, please.
My comment is that I am extremely happy of this day and this afternoon, because I have the experience of many colleagues that have a very good casuistic of this. And really, I am extremely happy. Thank you all, because I think that the argument of the esophageal replacement and the esophageal atresia is really treated all aspects of this pathology, and this problem is treated. Yeah. Senior chairman, what is your opinion?
Well, I thought you should close the session, but I'm going to say some words. I'm extremely happy. I think that the day has been a very complete overview of the problem. I am surprised that we still keep 116 participants that are alive after so many hours of session. So that means that they are interested. And I think that the set of presenters and discussants has been, very cooperative, and I enjoyed really very much the session. And I have to say, Mario, that the educational work you are doing in Bologna is absolutely outstanding, and I congratulate you on that. And I think that we will go on this type of meetings, and we will be very happy to assist or contribute or just listen to the presentations in the future. Thank you very much, and congratulations.
As a junior chairman, Mario, sorry, as a junior chairman, I need to echo
you are the young chairman.
Don't ask me about my real age. No, it must be echoed. It's so brilliant that 140 participants are still there. This speaks for the format that you created and this wonderful day. This speaks for every presenter that worked hard to make the best out of it. And that speaks for the topic and the design of all of it. So congrats to you and your team. It has been an outstanding experience for us. Thanks.
Please see the chat, because Gabriel Anthony Villa from the Philippines is colleagued with us. Yes. This is a very surprise. It's a very good surprise. And I thank you very much, Giovanna. Thank you very much, Massimo, for your very important contribution. Giovanna, we are the new Fellini, because it's the regia of the meeting of the operative theater. Yes.
Oh no, it's true that I came from the same region. So.
Yes, same region and same land, because Romagna.
Same land.
Thank you very much. All for me is a very honor to have, and I want to remember the next appointment, that is the 30th of March, with the surgery and minimally invasive surgery of the ureteral reimplantation. Holger, you are ready? Holger, you are
Almost.
ready?
Every
Yes, almost.
anytime,
Okay.
sir. Anytime.
Always.
Yeah, the name of the nickname of Holger is the younger chairman. It's okay.
Okay. Thank you very much, Mario. Thank you to all of you.
Thank you to everybody.
Arrivederci
Bye
a tutti.
bye.
Ciao,
Thank you very much.
Arrivederci. Bye.
Arrivederci.
Ciao.
Bye bye.
Ciao.
Bye.
Ciao.